Indeed, we have great pleasure in bringing this Neuro-ophthalmology emergencies webinar to all of you. We have a very elite panel of neuro-ophthalmologists in this team today, and I'm sure you will gain a lot of knowledge, experience, and tips from all these speakers today. Neuro-ophthalmic emergencies are something that are areas where you shouldn't miss many of the diagnoses that we're going to say today, and I'm sure it is important for all ophthalmologists, postgraduates, specialists across all subspecialties. Everyone will be benefited from this webinar. So with these few words of introduction, I request Dr. Neena, who's a neuro-ophthalmologist at Giridhara Institute, Cochin, who will be basically taking you through this entire program. Dr. Neena, can you please make the opening remarks and introduce the speakers, and then we'll get on with things. Dr. Neena, please.
I think Neena, please unmute.
Unmute, Neena. Dr. Neena, you have to unmute yourself and start speaking.
Okay, is it now? Am I audible?
Yeah, now perfect, perfect.
Yeah.
Please go on. Yeah.
Okay, a very warm welcome to one and all. We are starting our neuro-ophthalmology webinar. It is on neuro-ophthalmic emergencies you don't want to miss. It was aimed to be a case-based approach. We have a very elite panel of speakers today. So we have Dr. Rohit Saxena, Dr. Pradeep Sharma from RP Center. Then we have Dr. Sachin Kedar from Nebraska, USA. Then we have Dr. Rashmik Gandhi from Hyderabad. Then Dr. M.B. Francis from Chertala, who is an authority on headache. We have Dr. Naveen Jaykumar from Chennai and myself. Then we will also be having two eminent panelists, Dr. Revati, who's a neuro-ophthalmologist at Tony's Eye Hospital, Kochi, and Dr. Suresh Kumar, who's a neurologist at Amrita Institute of Medical Sciences, Kochi. They will be our panelists who will give us their expert comments. So since there is a small change in the program, since Dr. Rohit wants to be at a different program at around 6:30, the first talk will be done by Dr. Rohit Saxena. Over to you, Dr. Rohit.
Thank you, Cochin Ophthalmic Club, Dr. Sai Kumar, Dr. Gopal, and Dr. Neena.
Dr. Rohit, just before you speak, I'd like to introduce you to the panelists and to the audience.
Okay.
Just 2 minutes, please. So we're all familiar with Dr. Rohit Saxena. Nevertheless, I'll introduce him. He is currently the additional professor of strabismus, pediatric ophthalmology, and neuro-ophthalmology at RP Center, New Delhi. He's also a keen researcher and a PhD holder in ophthalmology. He has more than 100 articles in index journals. He has won many awards at national and international levels. Apart from these accolades, he has authored 2 books and written 32 chapters in national and international books. He's also an avid teacher and a very good orator. He's going to talk to us on sudden onset of painful ophthalmoplegia, presentation and diagnosis of orbital causes. Over to you, Dr. Rohit Saxena.
Thank you. I hope my slide is visible.
Yes.
Thank you. So I'll be talking to you about sudden onset painful ophthalmoplegia, and basically it will consist of periorbital or hemicranial pain with ipsilateral oculomotor nerve palsy. So one or more nerves are affected and the patient will complain of ipsilateral pain. So this is the presentation that we are not uncommonly faced with. And the pain is essentially because of a mass effect of vascular structures or stretching of the dura or involvement of the trigeminal nerve. And the ophthalmoplegia would be limitation of any one of the third, fourth, or the sixth cranial nerves. Along with that, you may not have involvement of the optic nerve or the second cranial nerve. So when you have this constellation of symptoms, the key thing in any neuro-ophthalmological condition is to kind of localize where it's going to be. So with these, this is the only place is the orbit right up to the cavernous sinus that these features can come together. So it could be an intraorbital lesion, an orbital apical lesion, superior orbital fissure, or cavernous sinus. And all these have slight differences, and although they're very close to each other, it's actually possible to predict, to have an idea where exactly the lesion is. Orbital lesions would have severe proptosis, chemosis, paresis, and more often than not coming to a neuro-ophthalmologist, they go to orbital surgeons, or not so difficult, but you could have infections, inflammations, you could have non-specific orbital inflammations or orbital pseudotumor, you could have thyroid orbitopathy and orbital cellulitis. So these are the key findings or key things that you are looking for in an orbital cause. But when you're localizing with the third, fourth, sixth cranial nerve with the V1 or the ophthalmic division of the trigeminal nerve with pupillary involvement with pain, you have, as I said, three things. So if the optic nerve is involved, you're looking at the orbital apex where these three come together. If the optic nerve is not involved, it could be at the superior orbital fissure. And if it involves the V2 division also, you're pretty localizing it well to the cavernous sinus. So the orbital apex would involve, other than these findings, also some amount of proptosis, ptosis, chemosis with periorbital facial pain, and an afferent defect if it involves the optic nerve, depending upon the severity of involvement. The superior orbital fissure would also have a little bit of proptosis, although unless the lesion is very large, it's very subtle, there would be paresthesias and a fixed dilated pupil. Again, this is the superior ophthalmic fissure, orbital fissure, and the nerves here and its proximity to the optic nerve can result in the optic nerve also getting involved as it moves anteriorly. And in the cavernous sinus, you have all these nerves passing through along along with the internal carotid artery. So any lesions in the carotid artery or its carotocavernous fistulas or cavernous sinus thrombosis, all these would have the features along with proptosis, chemosis. But along with that, if there's an infection or inflammation, you can have fever, tachycardia, hypotension, rigors, altered mental status. So these are again important signs. If you have a lesion in the orbit and these are the signs that are developing in a patient, you know that the infection or inflammation is going posteriorly involving the cavernous sinus, and it becomes important to urgently image and possibly manage. These are all the possible etiologies, particularly trauma. If you have a trauma to the forehead and you have a fracture going right up to the orbital apex, you could have involvement of these nerves because of the bone affecting these nerves or the inflammation surrounding it. You can have ophthalmic migraine, and of course, other than that, you have a lot of other lesions which we'll discuss. So unless there is a clear cause that we know, like trauma, or there is a nasopharyngeal lesion that we know pre-exists, and it has possibly invaded into the orbit, an urgent investigation, possibly an MRI brain and orbits with contrast and fat suppression, needs to be ordered. And an etiological cause has to be worked up because a lot of these lesions, that list had a lot of lesions possibly that could affect here. So besides the complete blood count, ESR, you need a basic metabolic panel, a possibly thyroid function test, and an entire autoimmune workup, because a lot of orbital inflammation, sarcoidosis, Wegener's, giant cell arteritis, all these are lesions that can present to us with acute presentations with painful ophthalmoplegia. Again, we'll see some examples of cases, but intracranial tumors moving anteriorly involving the cavernous sinus or entering into the orbit, then pituitary apoplexy, metastasis, a lot of local spread of the disease or distant spread of the disease to the orbit or the cavernous sinus, which is a highly vascular area. So these are possible things that you need to keep in mind. Often the MRI is very non-specific and not able to pick up anything, or it's not very diagnostic of anything. Among the possible differentials, then of course are a carotid artery aneurysm or a microvasculopathy, which is usually mononeuropathies, which would be discussed subsequently. So I would retain myself to ophthalmic migraine or ophthalmoplegic migraine and an idiopathic inflammation of the cavernous sinus of the SOF. So these are important differentials, or the most common differentials of painful ophthalmoplegia with without vision loss. Ophthalmoplegic migraine is not a very common thing and fairly rare, but a patient presenting with sudden loss of pain, ocular motility defects, and the problems lasting for a fair amount of period from days to weeks, which would often spontaneously resolve. and there's not much to imaging that we'll see. So that is, of course, in the setting of a patient having a history of migraine or previous similar episodes. The orbital idiopathic inflammation or a possible Tolosa-Hunt syndrome would be an idiopathic granulomatous inflammation with retroorbital pain, variable nerves involved, which could be the 3rd, 4th, 6th, and the V1, duration lasting from days to weeks. They may spontaneously remit and would have recurrent attacks. And the key thing to diagnose is to exclude other disease processes, which we'll be seeing. So it's not a common one, but not infrequently seen and usually unilateral. And the other features you could see would be proptosis, ptosis, chemosis, diplopia, and facial paresthesias. We manage by high-dose steroids with 2 to 4 weeks, followed by a gradual taper, which could last up to several months. You have a very good initial response with pain relief happening within 1 to 3 days. And the prognosis is usually very good, although we know that relapses can happen. And a repeat MRI may be required to see how to taper the steroids. And until all the findings are absolutely normal, you would require to continue steroids for low days. So I'll just run through some series of cases. So this is a typical case that we usually see. A 34-year-old female presented to us with periocular pain with decreased vision for about 3 months. 3 months ago, she had dexamethasone given for possible diagnosis of optic neuritis with marginal improvement and decrease in pain. But within a couple of months, the episode again recurred, and then she came to us. She had drooping of the left lid, limitation of movements, and proptosis. So you can see the ptosis, you can see the limitation of movement, which is pretty significant in all directions. There was a relative afferent pupillary defect and a little optic atrophy on the fundus. So, like I said, the key investigation of choice is an MRI brain and orbits with contrast with fat suppression. And you can see that there was a bulky optic nerve with soft tissue lesion at the orbital apex with involvement of the lateral wall of the cavernous sinus with enhancement. So we have an inflammatory lesion localizing there, a possible diagnosis Tolosa-Hunt, and we treated with oral steroids for at least 3 weeks, and at 6 weeks, for 6 weeks, and you can see at 6 weeks, you can see the significant improvement that the patient has in the ocular motility. So Tolosa-Hunt syndrome responds very well to oral steroids. Another acute painful ophthalmoplegia, a 75-year-old female came to emergency, severe headache, bilateral total ophthalmoplegia, severe visual loss, sluggish pupils. You can have conjunctival chemosis with severe disc edema. Of course, we couldn't wait for an MRI, and in her condition, an urgent CT was advised. You can see that the dilated tortuous superior ophthalmic veins are seen on both sides, and a cavernous sinus thrombosis. She had a bilateral cavernous sinus thrombosis because of a systemic disease. She had simultaneously a malignancy, and that's acute presentation requiring an acute investigation and management. Another 32-year-old male presented to us with diplopia for 4 days with left-sided periocular pain. You can see the mild proptosis that is there in this eye. He didn't have any visual symptoms. But again, an MRI brain and orbits showed us an orbital, apical, and anterior cavernous sinus showing an asymmetric lesion here and slight bulkiness of the extraocular muscles, particularly the lateral rectus. Again, an inflammatory lesion, possibly Tolosa-Hunt. Again, post 1 month of oral steroids, you can see the improvement. Now, this was a very interesting patient. He came to us with bilateral ophthalmoplegia, had a history of gunshot wound 1 month ago, and he presented with bilateral loss of vision, inability to open both eyes, and he had a severe ocular motility defect. In fact, he was referred as malingering because of the history of gunshot wound, and he was referred that possibly malingering. Now, this was also, although the VEPs were unrecorded, but it could be possible that the patient was not looking at the light and not looking at all at the stimulus given. The X-ray was showing some variable amount of lesions that were there, but nothing that could explain. So he was carrying this X-ray. So because of that, we got a CT scan done, and this was the image that you can see. So exactly at the struts adjacent to the optic nerve, you can see the bullets or the pellets have gone there and have caused this severe loss of vision, both eyes with ocular motility defects. So orbital apical syndrome post-trauma. So trauma, an important cause, of course. Road traffic accidents are the ones which are more commonly presenting with this, but this was an unusual presentation. Another case of motility defect, painful decrease of vision with limited ocular motility with lid droop. So always, whenever there is one nerve involved, check for all the other nerves. So even in some cases, there may be a very subtle other nerve involvement, and that can help us to localize the lesion to the orbital apex, especially if the V1 is involved. Again, here you can see it. There was a lesion here, a hyperintense lesion at the superior rectus close to the orbital apical belly, presenting to us with inflammation all around with a cystic lesion. And it was a cysticercosis, and we treated the patient with oral albendazole with prednisolone, and you can see the improvement. Although the loss of vision did not recover fully, but the ocular motility completely recovered. The important thing is to be always sensitive for ICSOLs. And again, a 60-year-old female presented to us with progressive loss of vision and motility defect with chemosis, and again an imaging showing us that there was encasement of the left cavernous sinus and involving the intraconal and intraorbital space. And to identify the lesion, a whole body PET scan was done, and there were multiple metastases all over, and she required chemotherapy and radiotherapy. So it could be presenting in unusual ways. Again, always be sensitive for ICSOLs. A 7-year-old girl actually presented to us for surgery. She had limitation of ocular motility and decrease of vision, which was told to us that it's congenital, and the vision is poor because of the ptosis and amblyopia. But we were a little suspicious because the way of the presentation, both third and sixth nerve palsy, we got her to get the old photographs, and it was normal, and you can see that it gradually increased. So again, we got an imaging done, and you can see that there was an gradually increasing intracavernous schwannoma, and obviously she went for resection before she went for squint surgery. And this was a patient who presented to us with sudden onset drooping of the left eye with deviation of the left eye, a left partial third nerve, non-pupil involving, no problem. He was carrying CT scans with him, absolutely normal, great. We got the entire profiling done, was normal, increased serum homocysteine, given vitamin D, be diagnosed as pupillary sparing oculomotor palsy, great. We were all very happy. 2 weeks later, he comes back to us with severe visual loss, pain, swelling of the upper lid, anisocoria. And again, we need to localize at the orbital apex, and you can see there was a very significant lesion involving the left optic nerve with fat stranding and involvement right up to the orbital apex. Again, evaluated him for systemic disease and malignancy, rest were all okay. A PET scan showed up, a lesion in the stomach suggestive of ulcer/carcinoma, and finally he turned out to have malignancy. So to conclude, painful ophthalmoplegia requires urgent workup. It can be a clinical dilemma, but if you work together with the constellation of signs, you possibly can localize the lesion. You will have to work with other associated specialists, and vascular causes like aneurysms can lead to severe complications and require urgent diagnosis and management. And for non-specific inflammation, you rule out other causes and can be fairly easy to manage. Thank you very much.
Thank you, Dr. Rohit, for that very elaborative talk covering all the aspects of orbital causes of painful ophthalmoplegia. I know it's a little, it's a tough topic, but you've done justice to it. I have a question. Very often we see patients with orbital apex syndrome, and the dilemma is whether to start steroids or not. So how do you differentiate an inflammatory condition, which could be a pseudotumor or something, from an infective condition like a granulomatous lesion or an abscess? So could you tell us some salient points which you would consider?
So of course, the key would be other ancillary signs, the severity of the inflammation or possible infection, chemosis. These would point, and of course, fever, the possible history. But more often than not, the imaging can help us to differentiate that this is a non-specific inflammation without severe infection. But when in doubt, you would probably have to give an antibiotic cover. But a steroid would be always given, even if there is an orbital infection, unless it's a fungal etiology, because you want to protect the associated structures, particularly the optic nerve, from getting damaged. So, like even in cases of cysticercosis, along with albendazole, you'll in fact have to start steroids and then think of albendazole. Otherwise, the inflammation would spread and cause more damage. So you need to essentially do a workup, do a CBC, of course, identify and try and find out if there is any infective foci again, the infection has to reach from somewhere, most commonly from the sinuses. So you need to assess the sinuses as well. And of course, if there is any other foci of infection, that may possibly be a cause. it can be, we've had a couple of patients who were, kind of having metastatic infective lesions that have come. But then again, they were multifocal. We had a patient who had orbital apical infection along with endophthalmitis. So that was an infection that had spread. But more often than not, isolated at that region is going to be more likely inflammatory than infective, because reaching infection there may not be that common unless from contagious regions.
Rohit, in that this thing, I want to ask you whether you would do a biopsy of that lesion at some point of time, one. And number two, when would you want to add an immunosuppression to the steroid, alternate immunosuppression also?
So biopsies are usually not recommended. I mean, that is a region where you are not it's not easy to approach, and you will have a lot of damage to associated structures. So unless the lesion is fairly anterior and it's going anteriorly, or the muscle thickening is fairly anterior, you would not think in terms of a biopsy. Usually it's presumptive, and an interventional like steroids improvement itself can be diagnostic. And yes, the alternatives of long-term steroids would have to be considered. So if a patient is diabetic, yes, you would want to quickly wean him off steroids and think in terms of immunosuppression. So azathioprine is a significantly frequently used alternative drug, especially in cases of Tolosa-Hunt syndrome. But again, the speed at which steroids work, you would always start with steroids, even in patients with diabetes, but you need to be careful. You need to differentiate between, again, infection there, especially fungal, because that can have a similar appearance. But usually there would be some different features of a fungal infection or a place from where it has come. But sometimes, yes, it may not be that easy to differentiate between.
What are the opinions of our neurologists? Any comments?
Yeah, I think what most important point, and that's a good question, because there have been instances where
Rashmin, audio not clear.
Rashmin is logged in two devices. You can close one, audio one.
there have been instances where steroids were given in a fungal infection behind the orbit or in cavernous sinus, and patient didn't do too well. I mean, it can really prove fatal. So, and it's, as Rohit said, it's very difficult to differentiate between the two, and you have to go by the fellow travelers. Is the patient diabetic and uncontrolled diabetes or any other features of immunosuppression? Then you suspect fungus and treat it as fungus before you start steroids. And as you said, sinus, most of the time sinuses are the culprits. And when in doubt, as Gopal also was mentioning, there have been instances where ENT surgeon will go and take some piece out and do the investigation before we start the steroid. So great question, and I agree with Rohit what you said.
Dr. Rohit, I have a question for you.
Yeah.
At which point in a patient with painful ophthalmoplegia would you decide to go in for an imaging?
So immediately, if you have a constellation of signs and a presentation, you need to diagnose urgently. So I would say the patient, the moment you have localized the lesion, you have you know where the lesion is. It's in the orbital apex or cavernous sinus. You need to image, because you could have very ominous conditions that could be there, which require an aneurysm there or a carotocavernous fistula there. So you need to image them very quickly before coming to a diagnosis. I mean, a presumptive treatment would really not. So the first step, like I had written very quickly, first step, image and then proceed. And of course, may consider other investigations along with that.
Dr. Rohit, there's a question on YouTube from Dr. Dave Thomas. He wants to know, how frequently do you see cavernous sinus thrombosis with infections in the dangerous area of the face?
So we do see them not infrequently, but thankfully they reach the neurologist before they reach us. And obviously management would be in association with a neurologist, but it's not infrequent, fairly common, especially inflammations around the face, even orbital infections going to the cavernous sinus can be fairly risky. Can I take your leave, and I'll be back in a bit?
Yes. Sorry for bombarding you with the questions. Thank you so much. We'll come back to you once you join us.
Yeah, thank you. Bye-bye.
I think at this point of time, Suresh and Sachin are our two neurologists. Can they also comment on this before we move on to the next talk?
Yeah, so as far as infections are concerned, remember that this is a deep-seated intracranial extradural infection. So associated signs are pretty high. You know, they'll have fever, systemic complaints. So more than infection, what I worry about is a neoplastic lesion like a lymphoma. So if you treat somebody with steroids without knowing if it's a lymphoma, you're never going to find out. So I maintain a low threshold for biopsy if it's accessible, if it is treatment resistant, or if patient has other systemic features like fever or high risk factors like diabetes, or if imaging studies show features suggestive of a fungal disease. So I will always get the oculoplastic person to look at it and get a second opinion about whether a biopsy is needed or not.
And your choice of immunosuppression would be azathioprine itself.
After steroids or methotrexate,
steroids.
yes, or methotrexate. So these are both non-specific immunosuppressing agents, so they both work well.
And how often is it that you require long-term immunosuppression, like 3-4 years or even longer?
You're talking about Tolosa Hunt?
Yeah.
So with Tolosa Hunt, I have rarely gone that far out. It's usually 1 to 2 years, and then you can start tapering them off. Now, the problem, as I said, is always recurrence. So if after the first tapering off, they have another recurrence, then I go much longer for the second time. And at that time, I usually end up getting a biopsy.
Suresh?
Dr. Suresh, you're muted.
By that time, you can ask the next speaker to
I just would like to invite Dr. Rehana Rashid to this webinar. I forgot to introduce her. She's also one of our key speakers. Welcome, Dr. Rehana.
Dr. Suresh, you were just going to answer.
Yeah, Suresh.
Yeah, I was just saying that sometimes Gopal was asking about a biopsy. And I would agree with Dr. Sachin that lymphoma is something which we usually presents in the orbital apex and in the orbit, and we may miss out a lymphoma. So basically, you need to get a biopsy at some point of time if you are not really happy with just giving steroids. I think you should also bring the ENT into play here, and ENT should see for fungal signs, because fungal mucormycosis, sinuses from the sinuses going into the orbits are very common in clinical practice, especially in diabetic patients. So I would also ask the ENT to come in and have a look at the sinuses, so that we don't miss. Actually Tolosa Hunt etc. is a diagnosis by exclusion. So we need to keep that in mind, that we have to exclude all related diagnoses before we start steroids. I think that is the message which should go.
I would just like to add one point. Although rare, in cases where imaging shows a picture similar to cysticercosis, but the scolices are not seen, we have to keep, especially in cases of children and immunosuppressed, the possibility of an isolated abscess in the extraocular muscles. These are not very common, but they have been found. And especially in children, they present with signs of infection. They have, along with ocular symptoms, they have febrile, etc. So if scolices are not seen, a cyst within an extraocular muscle, we should keep an abscess in mind.
Okay. Okay, madam, let's move on. Dr. Rehana is a neuro-ophthalmologist working with us at Amrita Institute of Medical Sciences. Over to Rehana, please.
Good evening, everyone. First of all, let me thank Cochin Ophthalmic Club for giving me here an opportunity to present. My topic is acute vision loss and dysgeusia. The causes of dyschedema can range from infections to vascular to malignant, but most of the time the patient's vision or life may depend upon a timely diagnosis, and so prompt diagnosis is very important. Dyschedema can be either bilateral or unilateral, and it can be associated with affected vision, or the vision may not be affected at all. So here we are going to through a few cases where the dyschedema is associated with vision affected. The dyschedema can be associated with or without the retinal surrounding retinal feature. For example, in certain cases like papillitis associated with uveitis, you can see other features of uveitis like vasculitis or cells of flare, where the diagnosis become obvious, or in cases like central retinal vein occlusion, it will be associated with hemorrhages and cotton wool spots. Again, it's obvious. Ultimately, the diagnosis depends upon the history, the clinical examination findings, both ophthalmologic and neurological, and ancillary tests to come to a diagnosis. There are lots of causes of optic dyschedema with decreased vision. One is inflammation, atypical optic neuritis or infections, ischemia, both arthritic and non-arthritic anti-ischemic optic neuropathy, infiltrations like lymphomas, leukemias, or any other malignancies, hereditary causes like Leber's optic neuropathy. Malignant hypertension can sometimes cause decreased vision either due to exudation at the macula or due to the ischemic component of the optic nerve. Compression, tumors, Graves, or increased ICP, or any lesions pressing on the optic nerve. Others like hypertony, central retinal vein occlusion, papillitis, or diabetic papillopathy. So I'll go through a few cases with some of these diagnoses. The first case is a 31-year-old lady who presented with decreased vision in the right eye for past 3 days. There was pain on movement of the eye, no past ocular or relevant medical history. Her visual acuity in the right eye was 636 and in the left eye was 66. There was a relative afferent pupillary defect in the right eye and a defective color vision on Ishihara chart. So here we can see there is dyschedema. The surrounding retina was normal. There was no vasculitis. There were no cells of flare. Left eye normal. Peripapillary RNFL thickening confirmed on OCT, and the Humphrey visual field showed centrocecal scotoma. So that was a case of a typical optic neuritis. Young female presenting with decreased vision, moderate vision loss, RAPD, and centrocecal scotomas. So how do you go about with this case? Every patient with typical optic neuritis should undergo MRI of the brain and orbit with contrast. First, to see the explanatory inflammatory lesion in the optic nerve and to exclude other causes. Here we can see the enhancing right optic nerve post-contrast, and also to see if there are any white matter lesions which are suggestive of MS, periventricular white matter lesions, which would help to diagnose MS, which is a common cause for typical optic neuritis. And all patients with typical optic neuritis, we do send them for neurology evaluation for CSF examination. Even though the MRI is normal, that would help because the presence of oligoclonal bands on the CSF, which is not present in the concomitant serum, would help to refine the risk assessment for conversion to MS, and they may be candidates for early disease-modifying therapy. Treatment, as we always give IV methylprednisolone followed by oral steroids for typical optic neuritis. ONTT says that by giving IV systemic steroids, IV methylprednisolone, it would help to hasten the recovery, but it will not affect the final visual outcome. But in our population, it's not just the typical optic neuritis we see a significant number of atypical optic neuritis too. So let's go through the second case, which is a case of decreased vision in the left eye in a 40-year-old male with right disc normal, some amount of peripapillary atrophy, the left eye showing dyschedema with some amount of hemorrhages. But this is not a case of typical optic neuritis because the vision loss is severe. And the features which are against typical optic neuritis are severe vision loss, bilaterality, no pain or eye movement, or not responding to steroids. So he underwent MRI of the brain and orbit with contrast, and you could see this hyper-enhancing lesion post-contrast in the optic nerve in the left eye, which again you can see as we go posteriorly to the prechiasmic level, which means that a long segment of the optic nerve is involved here, which could be, which is something typical or which is something suggestive of neuromyelitis optica. And the brain spinal cord showed enhancing lesions, that is longer segment involvement. That is again a feature of neuromyelitis optica. Neuromyelitis optica is an inflammatory demyelinating condition which affects the optic nerve and the spinal cord. The patient underwent CSF studies which showed NMO IgG positive, and so the diagnosis is optic neuritis associated with neuromyelitis spectral disorders. All these patients are co-managed with the neurologist. This patient obtain IV methylprednisolone, and that is a treatment, acute treatment, followed by oral steroids. But the case of neuromyelitis optica, optic neuritis, behaves differently from typical optic neuritis. They can present with poor vision, and the prognosis is also poor. So in cases where there is no improvement during the steroid treatment, they should be considered for either plasma exchange or IVIG, and they require long-term immunosuppressants, contrary to MS-related optic neuritis, where they get disease-modifying treatment. So when do you consider a typical optic neuritis? If the age is outside the typical 20 to 45 years, if there is bilateral optic neuritis, severe vision loss, painless, vision not improving or is worsening with systemic steroids, optic neuritis recurs when steroids are tapered, or if there is severe disc swelling. What are the causes of atypical optic neuritis? Inflammatory causes, sarcoidosis, chronic relapsing inflammatory optic neuropathy, which is a condition where the optic neuritis is steroid dependent with no underlying systemic cause found. SLE vaginus, autoimmune optic neuropathy, neuromyelitis optica, as we have seen in the second case, Moog optic neuritis, which is again different from the MS-related optic neuritis, where the patient can present with bilateral or severe vision loss, but it has a better prognosis compared to NMO or infectious conditions. How do you work up a case of atypical optic neuritis? They requires MRI and CSF, as we have seen in the previous cases. Again, to look for the underlying cause, they need an infective inflammatory workup. They require TB, quantiferon, autoimmune profile, ACE, syphilis, VDRL, serological and CSF test, and NMO antibody test and more suggested for individuals with bilateral optic neuritis. And in our hospital, with in our neurology department, all cases of atypical neuritis, they do get NMO antibody and more testing done. The next is a very different case from the compared to the first and the second. Here, this patient is an immunosuppressed patient, non-Hodgkin's lymphoma on chemotherapy, presented with decreased vision of 6/12 in the right eye with RAPD. Here, there is disc edema, but at the same time, you can see a lot of hemorrhages and few whitish lesions around with this retinitis and vasculitis around the optic nerve. And obviously, the diagnosis is here looking at us. It's a case of CMV optic neuritis. Here, optic neuritis with extrapapillary retinitis. This patient doesn't require extensive workup like MRI or CSF studies. He requires systemic anciclovir, and that was how he was treated. Now, the next case is a 55-year-old poorly controlled diabetic patient who presented with a decreased vision in the left eye. Vision in the left eye was 6/12. There was RAPD in the left eye. And look at the disc. The disc is having sectoral pallid disc edema superiorly. So that is also, typical of non-arthritic anti-ischemic optic neuropathy. Anti-ischemic optic neuropathy, that is ischemia affecting the optic disc head, either due to hyperperfusion of the optic disc head. The peripapillary arnophil thickness was seen on OCT. And Humphrey visual field showed altitudinal visual field defect. That is very typical of anti-ischemic optic neuropathy. So how do you work up these patients? These patients, we should see what is underlying cause, whether there is any uncontrolled diabetes, hypertension. Look for the antihypertensives which he is taking, whether he's taking it at night. Is there a nocturnal hypertension which has been found to be most common cause of non-arthritic anti-ischemic optic neuropathy? Ask for history of sleep apnea, because sleep apnea has been found to be have strong association with non-arthritic anti-ischemic optic neuropathy. Lipid profile of the patient, or if none of these are found, any other systemic diseases, any hypercoagulable state which can cause anti-ischemic optic neuropathy. The fourth case, we have a 78-year-old male who presented with sudden drop in vision in the right eye. Visual acuity in the right eye was hand movements, and there was relative afferent pupillary defect. You can see this chalky white disc edema in the right eye. That type of disc edema in a 78-year-old lady, 78-year-old, we should think about anterior arthritic anti-ischemic optic neuropathy. And arthritic anti-ischemic optic neuropathy is anti-ischemic optic neuropathy associated with giant cell arthritis. So we need to go into the history of headache, malaise, anorexia, jaw claudication, that is pain on mastication, or temporal arteritis. Look for temporal arteries, whether it is palpable, whether it is tender. Ask for symptoms of polymyalgia rheumatica. These are some of the features suggestive of giant cell arteritis. And FFA, we can see complete choroidal ischemia. Here it is involving the medial short posterior ciliary arteries. Unlike the anterior, the non-arteritic anterior ischemic optic neuropathy, where there will be filling in the choroid, delay in filling of the choroid, but that would be involving just a watershed soon. But routinely, we don't perform FFA in case of non-arteritic anterior ischemic optic neuropathy or arteritic ischemic optic neuropathy. So, but how do you go about with the management? Any case presenting with such a presentation, they should be treated as an ophthalmic emergency. They should undergo complete blood count, ESR and C-reactive protein. In arteritic AAON, ESR C-reactive protein can be is very much elevated, and they should be started immediately on systemic steroids, not to save the affected eye, but to protect the other eye. And they should undergo a temporal artery biopsy, which should be done within 2 weeks of starting the steroids. Otherwise, a chance of getting a positive result is decreased. The next case, we have a young girl who presented with decreased vision in both eyes of 1 week duration, 5/60 vision in both eyes. This was the fundus appearance, massive disc edema, veins were dilated, torches, arteries, there was attenuation, AV crossing changes, and a lot of exudation at both the macula. Blood pressure was 220, 110. So this is a case of grade 4 hypertensive retinopathy, and always check blood pressure in bilateral disc edema. Bilateral grade 4 hypertensive retinopathy in most cases doesn't cause a decreased vision, but if there is associated exudation or if there is an ischemic component to it, that will cause decreased vision. The next case, we have a patient on anti-tuberculous treatment presented with sudden drop in vision in both eyes. He was on the 4th month of ATT. He was taking ethambutol. The right eye showed normal disc, left eye, there was disc edema and hyperemia with some amount of swelling. Vision was 636 in both eyes. So that is a case of toxic optic neuropathy associated with ethambutol. The treatment is we have to stop ethambutol, which was done in his case. And during follow-up, so that the vision improved to 6.6, but it's not always the case. We are seeing a lot of ethambutol, not a lot, more ethambutol optic neuropathy than before, after increasing the duration of ethambutol treatment to beyond 2 months. So the last case was a bit puzzling case for us. This was a 50-year-old lady who presented with bilateral, with severe headache and decreased vision in the left eye. Visual acuity in the left eye was 612, right eye was 6.6. So looking at the disc, there is bilateral disc edema. The first thought was papilledema. You have to rule out space occupying lesions. But here, if you look at the macular OCT, there is some subretinal fluid which is tracking onto the macula and also here in the left eye. But we do often see cases where subretinal fluid do track due to severe papilledema or disc edema into the macula. So we thought that this could be the cause of decreased vision in the left eye. Anyway, but MRI was normal. So MRI normal, headache with papilledema. The next thought was, is there an IIH? The patient was under the care of neurology. So he underwent CSF studies, but the operating pressure was normal, but the cell count was found to be increased. Then we thought about our diagnosis when we did a B scan, which showed diffuse choroidal thickening. So we think that we are dealing with a case of EKH because headache, the patient is having bilateral disc edema, sensory neural detachments, diffuse choroidal thickening. The patient didn't have any other signs, and also pyrocytosis on CSF. There are case reports in the literature which shows that the VKH can present as atypically as bilateral disc edema, and maybe sometimes misdiagnosed, and when the patient followed up, developed typical signs of VKH. He underwent, she was given systemic steroids, and there was a dramatic improvement in disc edema, improvement in visual acuity, and also the patient systemically as well became better. So to summarize, when dealing with the case of disc edema, a good history of presenting complaints, past ocular history, underlying systemic conditions like diabetes, uncontrolled hypertension, any vasculitis, underlying malignancies or systemic medication has to be taken, and a good ocular examination, including proptosis, to see if there is any underlying thyroid-related problems or orbital lesions, extraocular muscle, cranial nerve involvement, which can occur in papilledema, IIH, or multiple sclerosis. Slit lamp examination looking for cells or flare which can explain the cause of optic neuritis sometimes. Do not forget BP and relative afferent pupillary defect. Don't hesitate to investigate and work along with the physician, neurologist, and rheumatology team as required. Thank you.
Thank you, Rehna, for that very illustrative talk touching upon all the important causes of acute disc edema. There are a few questions in YouTube. Can I take them?
Yes, please.
Yeah, the first question is, how do you confirm early papilledema with good vision clinically?
Early papilledema, first, we do go for the history. Start with the history, whether the patient is having any headache, and check the vision, whether it is normal or not. Look for RAPD fields, whether there's an enlargement of blind spot or any visual field defect. Looking at the disc itself, whether there is blurring of the margins or is it a case of pseudopapilledema should be ruled out. Look at the disc, whether there is any spontaneous venous pulsations in the disc, whether there is any halo around the disc, which could be due to the peripapillary fullness. Look at the macula. Then, if in doubt, if there is any doubt for any optic disc drusen, we can put the patient on autofluorescence to see if there is any hyperautofluorescent lesions which can be seen. Do a B scan to see if there is any calcifications on the optic nerve. And another, in case of doubt, I do really go for fundus fluorescein angiography as well, because in case of early disc edema or papilledema, the disc leak, but in case of pseudopapilledema, usually it doesn't leak.
Okay, this is a question to the general, the neurologist. Does every case of optic neuritis require a CSF study before they go into a treatment of optic neuritis, or is an imaging and clinical characteristic of optic neuritis enough?
Looks like it depends on what type of optic neuritis we are looking into. Like if we are looking
Dr. Suresh, can you be a bit louder?
Okay, can you hear me right now?
Yes.
Yeah. So, see, Gopal, the optic neuritis, like if it's a unilateral optic neuritis, you're probably suspecting inflammatory demyelinating disease like multiple sclerosis. Then, of course, we do tend to do a CSF study to look for the oligoclonal band. So, because OCB positivity would help us in dissemination in time now. There was a time in 2010 McDonald's criteria when CSF was taken out of the evaluation of multiple sclerosis, and we could just make a diagnosis based on clinical and radiology. But now, in 2017 McDonald's criteria, CSF has come back into the diagnostic criteria once again. So you can show dissemination in time in a patient who's CSF oligoclonal band positivity. So, of course, if I'm looking at a case of NMO or MS or MOG, I do tend to do, a CSF study. Sometimes CSF study also helps, like she was, Dr. was telling about Vogt-Koyanagi-Harada syndrome. Usually they present like chronic meningitis to us, and and we usually ask the ophthalmologist to carefully look at the eye. So looking for findings of Vogt-Koyanagi-Harada syndrome. So chronic meningitis presentation with tuberculosis, sarcoidosis, Lyme's disease. There are so many diseases which present with optic neuritis and CSF finding. So probably I tend to do off a CSF in all patients where I am looking at an optic neuritis.
I think the question was, should all cases of optic neuritis be seen by a neurologist before starting IV methylprednisolone? I personally feel that optic neuritis is a clinical diagnosis. You don't really need many investigations to support your diagnosis. You only need an MRI for prognostication, and all atypical neuritis I do send to the neurologist, and I do the second level of investigations.
So that brings us to the next question. How do you define a typical optic neuritis versus atypical optic neuritis, and which are the atypical optic neuritis which we require to send to a neurologist?
I think Dr. Rehna elaborated on it. Dr. Sachin, would you like to add anything?
Yeah, so the typical optic neuritis is what was defined by the ONTT criteria, which is a young female with a unilateral optic neuritis, painful eye movements, not a severe vision loss, recovers spontaneously by about 6 to 8 weeks, and you can give steroids and shorten that duration of vision loss. So the features that would define atypical optic neuritis would be outside of this age group: severe disc swelling, no light perception vision, presence of disc hemorrhages or retinal hemorrhages, presence of uveitis. All of that would put it in a atypical category. So for me, I agree that optic neuritis is a clinical diagnosis. So you don't need anything else for diagnosing optic neuritis. I tend to use imaging these days with every patient with optic neuritis because it gives you other etiologies that we are now aware of. CSF, I use it mostly as a second line, which means once I've treated, if they're not behaving in a typical fashion, or as Dr. Suresh said, we now have the revised McDonald criteria where you want to document dissemination in time as one of the criteria for diagnosing multiple sclerosis. So I tend to be a little conservative with CSF even now, but that may change in the future as more and more definitive etiologies for optic neuritis comes into vogue.
Okay, Rashmin, yeah.
Yeah, so I agree with Sachin. There are a couple of points that I wanted to highlight, that MRI brain and orbit with contrast is now necessary. We should be advising in everybody because it's no longer prognostication, but we also want to see which segment of the optic nerve is affected because it'll give us a clue as to which direction this patient is going to take. Number one. Number two, Gopal, your question about typical versus atypical, please remember that typical was defined by ONTT and most of our patients even then were falling outside those criteria. And then RPC paper had shown that our typical is quite different from typical, which was described in ONTT. So there's always a confusion as to what is typical, what is atypical. Nowadays, even NMO and MOG, they are all being described as semi-typical or atypical because they fall outside the criteria of ONTT, but their prevalence in our patients is much more than the typical.
Okay, so I want to bring in Dr. Pradeep Sharma sir here. Sir, out of 100 patients of optic neuritis, how many would you think that would fill the criteria of ONTT typical optic neuritis, and what percentage would be somewhere around MOG or neuromyelitis optica or other uncommon optic neuritis?
I think mostly that we see in North India, we get about, I think the majority of the optic neuritis will come out 50 to 60% in the typical group. The rest 40% is the non-NMOs or the atypical ones, maybe having infective origins, or maybe MOGs we rarely see, or we actually have not done much of the test for that. And the 20 to 25% would be the NMO variety that we have.
No, I would rapidly want to ask Rashmin, Suresh, and Sachin the same question. So
I agree with Dr. Sharma. The majority of patients, when you have clinically diagnosed optic neuritis, end up being typical. 1/3 of the patients will end up being atypical. The atypical is an enormous basket. So that'll include infectious causes. It'll include other non-inflammatory causes, such as MOG, NMO, or even seronegative CREON, which is chronic relapsing inflammatory optic neuropathy. You'll have sarcoidosis, lupus, it's a wastebasket diagnosis. And that's the reason once you enter atypical optic neuritis category, you need to get more imaging. So, adding to what Rashmin said, I do get MRI brain and orbit for patients with optic neuritis, but I also end up getting MRI pan-spine. So we actually image the entire neuraxis because it helps us with the neurological diagnosis. And in all atypical optic neuritis, I will get CSF.
Yeah, I think
just one question. In this COVID era, does COVID-19 present as optic neuritis?
Short answer is yes. So I have seen a patient with optic neuritis about 2 weeks after COVID. So it's a post-infectious inflammatory disease. Yes.
And I have also seen patients with multiple sclerosis getting optic neuritic relapses in this COVID-19 time. So relapses of multiple sclerosis, optic neuritis is being very much seen in COVID.
I think we will move on to the third talk.
Revati madam, any final comments before we move on? Revati madam? Muted, you're muted, sorry.
I would like Dr. Pradeep Sharma to actually highlight on the type of optic neuritis that we see in our Indian population, which is slightly different from the textbook description of optic neuritis, because several of these patients, although they have most of the features of a typical optic neuritis, they do have some specific signs that we see here in India. So, Dr. Pradeep.
So many of them we see are isolated to involving the optic nerve alone, and they don't progress to a multiple sclerosis. So which is a good thing, that it's restricted to the optic nerve and not involving the rest of the white matter that we have in multiple sclerosis. So fortunately, this kind of variety, which is non-MS, you might say, that is commoner that we see. But they are typical because they start recovering in the first week itself, and by 2 weeks, the recovery has occurred. So once we see that the recovery is there, we can diagnose clinically and put them on the follow-up. And if they have already come to 618, we don't even give steroids in those cases. We only give the IV methylprednisolone or IV dexamethasone for those cases which have not improved up to 618 vision, or they are not showing recovery in the first week.
Can we move on to the next talk, Dr. Gopal?
Yeah, please.
Yeah. So we missed the first talk. We'll come to that talk later. Now we invite Dr. Sachin Kedar to give his presentation on acute field loss, localizing lesions based on the field defects. Dr. Sachin Kedar is an alumni of RP Center, New Delhi. He has done his MBBS and MS from AIIMS, New Delhi, and a fellowship in Neuroophthalmology from Emory University, and residency in neurology from University of Mississippi Medical Center. He has also obtained a clinical neurophysiology fellowship from there. He's a fellow of American Academy of Neurology and North American Neuroophthalmic Society. He's currently a tenured professor of neurological sciences, ophthalmology, and visual sciences at University of Nebraska Medical Center and Stanley Twizel Eye Institute. He has many teaching awards to his credit. His current research interests include novel teaching methods, ophthalmological biomarkers in neurology, clinical trials in neuroophthalmology, and his clinical interests lie in all forms of visual disorders. Over to you, Dr. Sachin.
Well, thank you so much. Well, thank you so much for the kind invitation. Hello, can you hear?
Yes.
Okay. It's a pleasure to be here with many familiar faces. And I know next week was supposed to be the Indian Neuro-Ophthalmology Society meeting, but unfortunately got canceled due to COVID. And maybe we can touch base next year for the same. But in the meanwhile, I think this webinar will do for neuro-ophthalmology teaching. So the goal for today's talk for me is to localize neurological lesions based on visual deficits using a case-based approach. So I will use about 5 cases to demonstrate how the visual deficits and its analysis can help in generating differentials and management for a patient presenting with vision loss. So let's dive into case 1. This is a very, what should I say, typical case that one might see in the ophthalmology clinic. It's a 55-year-old who wakes up with painful decreased vision in the left eye, has reduced visual acuity in the left eye, along with reduced color and contrast sensitivity and a left RAPD. The fundus shows left optic disc swelling. And as you can see, there are many atypical features of optic neuritis over here. So if you look at the visual field, you will say that this is a left inferior arcuate field defect, and it immediately localizes the lesion to the left prechiasmatic pathway, classically the optic nerve. So as everybody on this webinar is aware, a prechiasmatic lesion typically produces visual deficits in one eye, unless it's a bilateral optic nerve disease. It will lead to RAPD if there is significant difference between the two eyes. And the optic nerve can appear either normal, swollen, or pale, depending upon the site of the lesion and the duration of the lesion. To understand the visual deficits that one sees in diseases of the optic nerve, it is important to know the relevant anatomy of the retinal nerve fiber. So if you look at the picture on the left, we all know that the retinal nerve fiber layer is separated across the horizontal raphe, and hence lesions of the retinal nerve fiber and the optic nerve will produce visual field defects that respect the horizontal meridian. The second important point to know is that the visual field is split across the fovea and not across the disc. This is important because the temporal visual field is served by retina that is both nasal and temporal to the optic disc, whereas the nasal field is essentially served by the retina which is temporal to the fovea. Third important point is to know how the retinal nerve fiber layer enter and are arranged in the optic nerve. So the more peripheral fibers enter and lie peripherally within the optic disc, whereas the more central fibers enter and are located more centrally within the optic disc. This is important because in patients with papilledema, it's the peripheral fibers that are affected as they are crushed against the scleral canal, and you will start seeing peripheral visual field defects. Whereas in patients with optic neuritis and ischemia, will have central fibers are affected and hence get a central visual field defect. It's also useful to know how the retinal nerve fiber or ganglion cells are distributed across the retina. Now, if you overlay them on a Goldmann visual field, you will see that about 2/3 of all the ganglion cells serve the central 30 degrees of the visual field. It is for this reason that your automated perimetry strategy of 30-2 will give you pretty much all the information you need without going to a full perimetry. So based on this information, you now can understand why we see the various visual field defect patterns in prechiasmatic lesions. So you will see a nasal step, which respects the horizontal meridian. You will see an arcuate scotoma, which also respects the horizontal meridian. In extreme cases such as AION, you might see an altitudinal defect. You might see a temporal wedge defect. You might see a scotoma in an arcuate bundle. And if the papillomacular fibers are affected, you will see a cecocentral scotoma. The take-home message over here is that all chronic optic neuropathies behave pretty much the same way, and you cannot use the visual fields to differentiate between the etiologies. So given the right scenario, you can see all of these defects in all optic neuropathies. So our patient had an MRI of the brain and orbits with fat suppression, and as you can see on the MRI section over here, the optic nerve showed diffuse enhancement along its entirety, including the anterior part of the optic nerve, which is why there was swelling. There was also enhancement of the optic nerve sheath as well as the orbital tissue. Turns out to be MOG immunoglobulin positive, so this is a MOG IgG related disease. She was treated with IV solumedrol for 5 days, followed by 8-week steroid taper, which is much more prolonged than normal, because we suspected atypical optic neuritis. She had 2 relapses, which resulted with her being treated with rituximab, and she has remained relapse-free for almost 2 years now. So let's move to case 2. This is a 50-year-old who presents with a 1-week history of peripheral vision loss, headache, and excessive fatigue. Visual loss is essentially normal with normal color, contrast, pupils, and fundus. So these are the visual fields for this patient. And as you would have recognized, it is a bitemporal hemianopia, which points towards a lesion of the optic chiasm. These are mid-sagittal sections of MRI, which shows us that the optic chiasm lies just about above the sella turcica and is separated from it by the suprasellar cistern. But a lesion of the sella, which grows superiorly, can crush and elevate the optic chiasm. So let us look at the optic chiasm anatomy to understand the visual field defects in this region. So the chiasm comprises of the crossing or decussating nasal fibers from the two retina. It's important to know that the superinasal part of the retina decussates superiorly in the chiasm, whereas the infranasal fibers decussate inferiorly in the optic chiasm. The importance of this anatomic fact is that a lesion that is inferior to the chiasm hits it on the undersurface, and the earliest visual field defects you see are bilateral supratemporal visual fields. There are anatomic variants of the optic chiasm which change the visual field defects that one sees in this region. So in a prefixed chiasm, the optic nerve segment is short, and the sella overlies the posterior part of the optic chiasm and the optic tract. In a post-fixed chiasm, the optic nerve segment is long, and hence a lesion of the sella will affect the optic nerve and the anterior part of the optic chiasm. These variants produce a plethora of visual field defects, as you can see over here. You can have the classic bitemporal visual field defect if the lesion is large enough. You can have a junctional scotoma, which is involvement of the optic nerve and the anterior chiasm, such as in a post-fixed chiasm. You can see a paracentral bitemporal visual field defect if the lesion is small enough to affect the posterior and central part of the chiasm. You can get the incongruous homonymous hemianopia in a prefixed chiasm because now the lesion is affecting the optic tract. And you can see a ultimate chiasmic lesion with a large enough paracellular lesion which crushes both the optic nerve and the chiasm completely. So the patient that I saw obviously demonstrated findings that were suspicious for pituitary apoplexy. They got an urgent MRI brain, and as you can see, there is a heterogeneous mass over here with areas of enhancement and blood products consistent with apoplexy. They were admitted to the hospital promptly because fatigue suggests low hormone levels. They were stabilized with hormone supplementation and eventually underwent transnasal transsphenoidal resection. Because the patient was diagnosed early and treated early, the visual feedbacks are now essentially back to normal. Case 3 is a 60-year-old patient who presents with a 3-month history of right eye vision loss, normal visual acuity, normal color and contrast, but has a right RAPD. So what are these visual field defects and where would you localize this lesion? So of course, this is a right homonymous hemianopia, which affects the left retrochiasmal pathway. But what about that right RAPD? How do you explain that? Further examination, I don't know how well this projects on the webinar, but this is a right optic nerve and you can clearly see a band-shaped atrophy of both the temporal part of the disc and the nasal part of the disc on the right side. On the left side, you can see more diffuse temporal optic atrophy, and perhaps the whole disc is paler compared to the right eye. These are ganglion cell thickness maps on the Heidelberg, and normally you should see a full bright red donut, but here you can see that the ganglion cell layer is lost in a hemianopic fashion on the right side. So this disease, or this syndrome, is called optic tract syndrome, which is a triad of contralateral homonymous hemianopia, contralateral RAPD, and optic atrophy. And this occurs because the optic tract is comprised of ipsilateral temporal retinal fibers and contralateral decussating nasal retinal fibers. Because there is asymmetry between the nasal and temporal retina, you get all of these symptoms, including the RAPD, because the nasal fibers are slightly more than the temporal fibers in the tract. So this patient was imaged promptly, and as you can see on the MRI, as opposed to this optic tract on the right, the left optic tract is atrophic. There is a small lacunar infarct involving the lentiform nucleus, the posterior internal capsule, and the optic tract. So because the optic tract had a stroke, there was a dieback of the axons all the way back into the retina. Patient had chronic hypertension, was a smoker. He was treated with antihypertensive medication, statin and aspirin, and was advised to quit smoking. Unfortunately, the visual field defect was permanent. So this is a summary of all the visual field defects that one might see in a retrochiasmic visual pathway. You can get an incongruous homonymous field defect from an optic tract lesion. You can get a complete homonymous heminopia, which is non-localizing, but can occur from lesions anywhere along the retrochiasmal pathway. Lateral geniculate nucleus can produce sectoral field defects, but these are extremely rare. I have seen maybe 1 or 2 in my entire career. You can get a pie in the sky or a superior homonymous field defect from a temporal optic tract, optic radiation lesion, or you can get a pie on the floor or an inferior homonymous defect from a parietal optic radiation lesion. Case number 4. It's a 60-year-old professor who has noticed difficulty with reading for 1 month. She has been to numerous ophthalmologists and optometrists, and refractive corrections have not helped her. When I see her, she has normal visual acuity for distance and near in both eyes, normal color, contrast, and pupillary reactions, normal fundus. But her visual fields show this. So this is an inferior right homonymous scotoma, which will localize the lesion to the superior bank of the left striate cortex. So here are some key features of the occipital lobe, which tell us how the visual field defects will behave when they are located in the occipital lobe. Most of these features are related to the fact that they are focused mainly on central vision. So cortical magnification tells us that the central visual field occupies a large area of the occipital lobe. The posterior part of the occipital lobe also has dual blood supply, and both of these are to preserve central vision. The fibers that serve a specific localization of the visual field approach very closely and fall into ocular dominance columns. As a result of these anatomic features, occipital lobe visual fields are highly congruous. They selectively spare or involve the macula. They can selectively spare or involve the ipsilateral, the unilateral temporal crescents. So as a result of these visual field defects, I promptly sent my patient for imaging, and as suspected, she did have a subacute ischemic infarct involving the superior bank of the left occipital striate cortex. She underwent a complete stroke evaluation and was found to have a vertebral artery dissection from trauma. She was started on antithrombotic treatment along with antihypertensive and statin. Unfortunately for her, the visual field defects did not improve. The reason why she was having reading difficulty is because this visual field defect interfered with the speed of her reading, and she would always miss words that followed her point of fixation. Case number 5. This is the last one. This is a 60-year-old professor of genealogy, which, as you might recall, is a study of family trees and family connections, who presents with complaints of headache, difficulty drawing and interpreting family trees, which she had done her entire life, recent memory loss, trouble reading and writing. So she had, again, normal visual acuity, normal color contrast, but was simply unable to do the visual fields. And because of her problems with recent memory loss and inability to do visual fields, I suspected that she did have some cognitive neurological difficulties. I screened her with the MoCA Cognitive Assessment Scale. The top part over here, as you notice, is a visuospatial assessment. And the first part of the task is called alternate trails making. As you can see, for a person who is used to drawing complex family trees, she is simply unable to connect the dots appropriately. Second task is to copy a cube down. And as you can see, there is no way she could do it. And this is a person who was otherwise of high intellect. The third task is a simple task, and this is something that I urge all of you to do if you suspect a cognitive lesion, is ask them to draw a clock. And as you can see, the numbers are all over the place. The hands are completely out of the face clock. All of this suggests a visuospatial lesion. She also had simultanagnosia, optic ataxia, which is an inability to do visually guided movements, Oculomoto Apraxia, which is an inability to guide your eyes in a specific path, dyscalculia in where localizes lesion to the parietal. So if you recollect, to pole, and from the information is transmitted on two streams, goes to the parietal lobe, and the beam. The dorsal stream is devoted to spatial processing. What does that mean? It means how are two images with respect to each other? How does the right and the left side of space differentiate each other? What about spatial transformation? If there's a moving object and they move across your visual field, how are they stitched together? The temporal stream is associated with object processing, which means the characteristics of the object, such as color, the texture, the shape, the size. In other words, the properties that help us identify that specific object. So again, this patient had imaging, and the MRI, as suspected, showed a large, rapidly progressing falcine mass in the parietal lesion, causing pressure effect on both parietal lobes, invasion of the sagittal sinus, mass effect, and edema. The mass was promptly removed by neurosurgery. Fortunately, it turned out to be WHO grade 1 meningioma. She received post-operative radiation and steroids, and eventually the signs and symptoms improved. So about 6 months later, this is the MoCA, and as you can see, the clock now resembles a clock. She has a much better effort at alternate trails making, some effort at making the cube, able to identify, name, and write all of the 3 animals depicted over here. So these were 5 cases which show us how the visual pathway help us interrogate the brain and identify certain life-threatening diseases. Thank you. I hope you guys enjoyed those 5 cases, and I'm ready for any questions.
Thank you, Dr. Sachin. That was a wonderful talk, beautifully illustrating all the visual pathway lesions. I think being a neurologist and an ophthalmologist is a double advantage to you, as you have been able to put all the clinical skills to use and wonderfully show us all the findings, how you came to the diagnosis. So I just wanted to ask you, and you stressed in your talk also, what is the visual field of choice if you're suspecting a neuroophthalmological condition? I understand it's the 30-2. Is that good enough, or would you like to comment anything on that?
Yeah, my default is actually a 24-2. And simply because it is fast, patients who are old can do it. For me, as opposed to say a glaucoma expert, I rely on the pattern of the visual field rather than on the absolute numbers. And there are very few things that you will miss by a central automated perimetry. You might miss a unilateral temporal crescent. or you might miss, a 10-degree constriction of the peripheral visual field. But it depends on what you're suspecting at any given time. So in most of the cases, I start with a 24-2, and then if I think on confrontation that I need to do a full perimetry, then I go to Gorman after that.
Dr. Revati and Dr. Suresh Kumar, would you like to add on to that talk?
I think that was a beautiful talk actually, and it demonstrated everything, what, the sites of the lesion and how we could come. Only thing I just like to add here is that many times, we do a confrontational method and in the clinic as a clinician in the outpatient. So some of these very small defects which Dr. Sachin was telling, you could actually miss out on a clinical examination in the outpatient setting. So if you are suspecting visual problems, then I think it's better to go for a full perimetry and an examination of the field, because some of these very peripheral or small central field defects can be easily missed by a clinical examination. I hope Dr. Sachin agrees to that.
Yes, I agree. If there are studies that have looked at the comparison between confrontation and automated perimetry, and if you use two separate confrontation techniques, then you can reduce the false negative errors by about 20–30%. The gold standard is using a 5mm red pin, which came out of England. But again, it is such a tedious task that you're better off getting standard automated perimetry.
I would also like to add that the case that Sachin showed, that homonymous hemiscotoma in a...
Dr. Rashmi, could you be a bit louder?
Yeah. So I would like to add that there have been instances where those homonymous hemiscotomas, which Sachin showed, can also be picked up by doing Amsler charting. So if you are not very sure, if you don't have a direct access to visual field, or if you just want to screen, Amsler as a screening tool, in addition to your confrontation, would also give you access information.
May I say something?
Just welcome Dr. Naveen Jayakumar sir also into this meeting. Naveen Jayakumar sir, your video is off.
Yeah.
Thanks.
No, I just wanted to say that excellent talk from Dr. Sachin, and just one thing, important thing he mentioned about the visual field, the choice of visual field, is that I think virtually every field of neuro-ophthalmic interest can be picked up on the central 30-2 of a Humphrey. I think the most important field, I think clinically important field, which might be missed on the central 30-2 is the upper nasal defect, the junctional scotoma. That it's quite possible to miss that, and which is why I keep saying to my students that whenever you see an optic nerve like a field defect in one eye in a neuro-ophthalmic situation, the more important field is the field of the fellow eye, especially when these things are there. A junctional scotoma, the corner can easily be missed, and you think it's an optic neuritis, but it's a pituitary tumor.
I would also like to add, that Sachin and Dr. Nancy and all had done a wonderful work a few years ago. So in a textbook, we keep seeing that more posterior you go, more congruous will be the defects. But they actually proved that even anterior, post-chiasmal anterior defects also presented with a congruous visual field defect. So it's not absolutely necessary that if you see a congruous defect, the lesion localizes only to the posterior part of the optic tract.
Perhaps one situation where the confrontation field would be of great interest would be when the patient presents with low acuity and we are unable to do a Humphrey field. In those situations, rather than give up on the patient and say that we cannot measure the fields, their confrontation fields would really come of use.
So I agree. In my clinic, all of my clinic lanes have the tangent screen, and I use it a lot when I suspect that I have to go outside the central 30 degrees. I also use size 5 stimulus on the Humphrey, and you can do that for patients who are, maybe count fingers or even 2100, 2200. You can easily use that. So I would encourage all of you to try the size 5 stimulus.
Yeah.
It is very comfortable for the patient. And I think within a few years, we are all going to see a shift away from size 3 to size 5 stimulus.
Dr. Pradeep Sharma and Dr. Francis, rapidly. And by the time Dr. Neena, you can share your presentation. Dr. Neena is neuro-ophthalmologist in Cochin at Giridhar Eye Institute. Pradeep Sharma sir and Francis sir. Yeah. Rohit, you wanted to say something?
No, I also was saying that size 5. I just wanted to add size 5. We do have the Goldman with us, but not so frequently used anymore. So Sachin would remember working on the Goldman when he was with us.
That's right.
Pradeep Sharma sir and Francis sir, any additions?
I think Sachin has covered a very nice.
I think Dr. Sharma is muted.
Yeah. Okay. Sharma sir?
No, I was saying that I really enjoyed Sachin's talk and it was a déjà vu. I specifically asked Gopal to have this talk because that is what we really enjoyed when you gave us in RPC to all our residents. It was wonderful. I think it's really something which is put in little time, so much information and so nicely done. It's really,
and I'm glad he didn't ask us the questions he was asking our residents.
Francis, sir, anything to add? Otherwise, we'll move on to the next talk. Yeah. Neena,
so, a very warm good evening to one and all. So I'll be talking on internuclear and supranuclear disorders of ocular motility, lesions and presentations. Can you all see my screen?
Yes, yes.
Okay. So as ophthalmologists, we're all familiar with the ocular movements, the 6 extraocular muscles supplied by the 3, 4, 6 cranial nerves with the nuclei in the brainstem. But how many of us know that we have a trifold control over this ocular movements? The first level is at the level of the cortex. The second level is at the level of the brainstem with the nuclei of the 3rd, 4th, and 6th cranial nerves and the internuclear connections. And the third level is the infranuclear pathway, which consists the cranial nerves themselves, the neuromuscular junctions, and the extraocular muscles supplied by them. So basically, from the neuroophthalmological point of view, all ocular movements aim to provide a clear image or to form a clear image on the retina. So on the basis of this, you can classify ocular movements into conjugate eye movements like versions or disconjugate movements in different directions called vergences or gaze shifting or gaze holding eye movements. So I'll be talking basically about horizontal and vertical gazes, their control centers and pathway. The thing to remember is that they have a final common pathway, but the horizontal and the vertical gazes have separate and distinct centers. So I'll come to each of this separately. So I'll just show you a small video. So can you see the video? So this gentleman is rapidly shifting his gaze between 2 pens held across his horizontal field. So these are horizontal saccades, rapid eye movements which aim to shift your gaze from one object to the other. So if you want to have a horizontal saccade, the command has to come from the contralateral frontal eye field. So for example, if I want to look towards to my right, it is my left frontal eye field which gives the command, and then it comes to the brainstem, to the pons, to a paramedian pontine reticular formation and 6th nerve nucleus. So it comes from the contralateral frontal eye field to the ipsilateral PPRF and the 6th nerve nucleus. You know, 6th nerve nucleus supplies the lateral rectus and an abduction movement of the right eye happens. Simultaneously, the 6th nerve communicates to the 3rd nerve of the opposite side via a channel known as the medial longitudinal fasciculus, and this makes the medial rectus contract and an adduction movement to the right also happens. So if I have to look towards my right, the command has to come from the left frontal eye field and a conjugate right movement happens. So when you look at the saccades, not only look at the speed, you look at the smoothness and the accuracy of the saccades. So thus we saw that the horizontal gaze center lies in the pons, and the final common pathway for all horizontal eye movements is via the paramedian pontine reticular formation and the 6th nerve nucleus. And the final eye movements are made by the 3rd and 6th cranial nerves respectively. Okay, now let's move on to pursuits. So this video shows you a horizontal pursuit. This young lady is pursuing or slowly tracking an pen which is moved across the horizontal visual field. Now, if you have to do this movement, this is a smoother, slower movement. The command has to come from the ipsilateral posterior parietal cortex or the parieto-occipital temporal cortex. So, from the same side parietal cortex, impulses come down to the same gaze center. The horizontal gaze center is the same. It is the PPRF and the sixth nerve nucleus via the MLF to the contralateral third nerve nucleus, again making a conjugate movement to the same side. So this time it is the same side of parietal cortex which tells you to move the eye to the same side. Okay, now a word about this paired white matter tract known as the medial longitudinal fasciculus. So if you can see this, this is a section of the midbrain and the pons. You can see this is the sagittal section. You can see this is the third nerve. If you imagine this, this is to be the third nerve at the level of the superior colliculus, and this the sixth nerve nucleus at the level of the pons. This is the channel which lies between the sixth nerve and third nerve. It's a communicating channel between the sixth nerve and the third nerve. So the thing to remember is that MLF is the final common pathway for all horizontal eye movements. In fact, it is the final common pathway for all sorts of conjugate eye movements. But just for now, for simplification, you just remember that it is the final communication pathway between the oculomotor nucleus, especially for horizontal eye movements. So much so that if you have a lesion of the MLF, it can produce an impaired horizontal eye movement. Okay, so that was about the horizontal gazes, and we saw that it was in the pons. Now we come to the vertical gaze centers. So the vertical gaze centers are located in the midbrain at the junction of the thalamo-mesencephalic junction. So you have two main nucleus, the rostral interstitial nucleus of the MLF and the interstitial nucleus of Cajal. So they again give their inputs to a final common pathway through the nuclei of the cranial nerves, third and fourth. Okay, so the thing to remember is that vertical gaze center is in the midbrain. So all other things may be confusing to you, but just remember that the vertical gaze center is in the midbrain. Okay, so now we will show you how a vertical saccade happens. So again, this gentleman is rapidly shifting his gaze between two pens held across vertically. And so these are vertical saccades. So now I already told you the saccades are generated from the frontal eye field. So again, they come to the vertical gaze center, which in this case is in the midbrain, the rostral interstitial MLF and interstitial nucleus of Cajal, coming to the third and fourth nerve nucleus, which will supply the concerned muscles responsible for the vertical eye movements. So what about the vertical pursuits? The same pathway. Pursuits are generated by the parietal cortex and it comes down. You see the video? So he's slowly tracking an object moved vertically. So the parietal cortex gives the command. It comes to the vertical gaze center in the midbrain, and finally impulses pass to the third and fourth nerve nucleus, which initiate the vertical eye movements. So that was that about the vertical and horizontal gaze centers. Apart from these cortical, supranuclear and internuclear connections, we have two peripheral controls over the horizontal and vertical gazes, and those are the vestibular ocular reflex and the optokinetic reflex. So I'll just tell you a few words about it. So what is vestibular ocular reflex? It's otherwise known as the oculocephalic reflex, so the doll's eye movement. The eyes move in a direction opposite to the head movement. So for example, if you have a left rotation of the head, that is sensed by the ampulla of the left horizontal semicircular canal, impulses will go to the left vestibular nucleus. Now, vestibular nuclei have connections to the opposite sixth nerve nucleus, and the sixth nerve nucleus, you know, supplies the lateral rectus, and it also has connections to the contralateral third nerve via the MLF. So, a conjugate movement to the right, to the opposite side, is made by this head movement. So, what does it do? Why does this happen? So, this is a reflex which aims to keep the image always focused on the retina, and even holds the head steady during brief head rotations. So it can be easily demonstrated by the doll's eye maneuver, which I'll demonstrate later. But what if you are not able to do this doll's eye maneuver? Suppose the patient has a neck injury. You can then do the caloric testing, which is by irrigating the semicircular canals with cold or warm water. Remember the mnemonic: curves, cold opposite and warm to the same side. So now coming to the optokinetic reflex. So what does this do? It thus what it does is it helps us to track a moving object with our eyes. So it's a combination of a tracking motion followed by a rapid snapping back motion. And it also aims to keep the retinal image steady with the movement of the object or with sustained head rotation. So you need an intact visual pathway for this, and you can actually use the optokinetic reflex as a test to rule out malingering in patients, because it's very difficult to suppress this if you have at least some amount of good vision. Let's say even 1 meters counting figures at 1 meter. So you can demonstrate this by rotating an optokinetic drum. If you have a vertical drum, you'll get a horizontal nystagmus and vice versa. So lastly, a word about the cerebellar control. So cerebellum is like a master modulator. It fine-tunes all the eye movements. So it suppresses the vestibulo-ocular reflex. It controls the smoothness of the pursuits, and it is responsible for the accuracy of the saccades. So that's the reason why in cerebellar lesions, you may sometimes get gaze abnormalities, like you may get hypermetric saccades. So apart from this, the thing to remember is that if you look at the second picture, you can see the vestibular nucleus has connections to the horizontal gaze center and the vertical gaze center, to cerebellum, to the vestibulospinal tract. So there are interconnections between all these control centers. So that's responsible for the fine-tuning of all the ocular movements. Okay, so that was that much about the control centers and the pathways. Now let's see some disorders affecting gaze. So first we'll see a cortical disorder affecting gaze. So I already told you saccades are generated by the contralateral frontal lobe. So if you see this video, this is an elderly lady who's having a seizure and a deviation of her eyes to the left side. Actually, she has an irritative lesion of the right frontal lobe, producing a contralateral gaze deviation. In contrast, if you look at the second video, this lady has a paralytic lesion of the right frontal lobe. She even has a left hemiplegia, and she has an ipsilateral gaze deviation to the right. She has an inability to look to the left side. So a paralytic lesion of the frontal lobe will produce an ipsilateral gaze deviation, whereas an irritative lesion of the frontal lobe will produce a contralateral gaze deviation. So as ophthalmologists, we don't often see such sick patients, but we do see a lot of patients with homonymous hemianopia. Now, as Dr. Sachin said, can we further localize it to the cortex? Can you further say whether this is a pure occipital lobe lesion or whether it is it's a parietal lobe lesion if you get a patient with homonymous hemianopia? You can, if you look at the ipsilateral pursuits. So if you have a patient with homonymous hanopia, and if the ipsilateral pursuit is defective, you can be sure that the parietal lobe is involved. At the same time, if the ipsilateral pursuits and the ipsilateral optokinetic reflexes are normal, you can be sure that it is a pure occipital lobe lesion and not involving the parietal lobe lesion. Okay, so I think that he beautifully demonstrated in that case in which the patient had simultechnosia and Oculomoto Apraxia. So now let's move on to the gaze palsies, horizontal gaze palsies. We'll see each one by one. So first, let's see the conjugate gaze palsy or lateral gaze palsy. So what does the lateral gaze palsy means? So you can see this picture. This patient is able to look wonderfully to the right, but on looking to the left, there is absolutely no abduction of the left eye and no adduction of the right eye. So where is the lesion? Now you can see I already told you PPRF and the 6 nerve nuclei in the pons are the horizontal gaze centers. So the lesion has to be either in the PPRF or in the 6th nerve nucleus. You can see here there is an infarct in the pons at the level of the 6th nerve. It's also seen in the sagittal MRI. So this has to be differentiated from a pure lateral rectus paresis, in which you will only get an abduction defect on the side of lesion, and there will not be any adduction defect on the contralateral side. Okay, coming to internuclear ophthalmoplegia. So what is internuclear ophthalmoplegia? The word itself says that there is some weakness between the internuclear connections. So what is the thing which connects the 6th nerve to the 6th nerve nucleus to the 3rd nerve nucleus? It is the medial longitudinal fasciculus. You can see here, it is the medial longitudinal fasciculus through which the 6th nerve communicates with the 3rd nerve. So if you have a lesion, let's say of the right MLF, patient cannot adduct the eye when there is a command to look to the left side. So when there is a command from the frontal eye field to look to the left, the PPRF is working. So impulses will go to the PPRF and the 6th nerve nucleus. The right lateral rectus, so the left lateral rectus will make a left abductive movement, but the right medial rectus cannot act because there is no MLF which is conducting the signal. So this will produce a pure adduction lag or pure adduction paralysis of the right side. I'll come to that with a video. You can understand it better. So it can be due to an acute infarct at the right MLF, as is shown here in this MRI. Okay, so let's see this video. So this gentleman had come to us with complaints of squinting and funny eye movements. You can see here, can you appreciate that when he looks to the left side, there is nystagmus, there is abduction happening in the left eye with a nystagmus of the abducting eye, but there is no adduction of the right eye. See what happens when he looks to the right side. The same thing. He's able to abduct the right eye, but there is no adduction of the left eye. And the abducting eyes show an ataxic nystagmus, which is also known as the dissociative nystagmus of INO. So this patient has wall-eyed binocular internuclear ophthalmoplegia or Webino, and he has bilateral pontine lesions responsible for that. Bilateral MLF lesions responsible for that. So what happens? What happens when he tries to look up? So you can see. I don't know whether you can appreciate that he has a vertical nystagmus. Can you see that he has a vertical nystagmus? It is downbeating, and in spite of all this, he has a vertical nystagmus. It is downbeating, and in spite of all these issues, he has got fairly some good amount of convergence. He can converge in spite of all this adduction weakness. He is able to converge, indicating that the convergence center need not be always affected in INO. It could be a pure MLF lesion here, which is producing this problem. So in young patients, always rule out multiple sclerosis. In adults or elderly patients, think about an infarct. Okay. So now we coming to the next lesion, which is 1.5 syndrome. So 1.5 syndrome means a lesion of the PPRF or sixth nerve nucleus of one side, along with the medial longitudinal fasciculus lesion of the same side. So as I already told you, a PPRF lesion will produce a total loss of conjugate movement to the same side. So you can see here, this patient is able to, on looking to the left, there is absolutely no movement. So left-sided PPRF or sixth nerve with MLF, no movement to the left. On looking to the right, there is an adduction limitation of the left eye, and the only movement which is happening is the contralateral abduction. So this is a 1.5 syndrome due to a lesion of the ipsilateral PPRF or sixth nerve nucleus and MLF. Okay, so we move on to the vertical gaze palsies. The common ones we see are the Parinaud's dorsal midbrain syndrome. So basically, this is a dorsal midbrain syndrome at this level, at the level of superior colliculus, often due to a compressive lesion of the rostral midbrain and pretectum. So this is the area where most of the oculomotor nuclei are located. So actually what happens is there is a loss of supranuclear inhibitory control to the oculomotor nuclei, and this produces all the important clinical signs of this condition, like a convergence retraction nystagmus, pupillary light near dissociation, upgaze palsy because of the involvement of the vertical gaze center, and Collier's lid retraction sign. So it could be anything which is producing this. It could be hydrocephalus, it could be a tumor. You can see this young lady has a characteristic sunset sign with conjugate downgaze in the primary position. She's not able to look up, and she has an upgaze palsy, and when she tries to look up, the eyes go into a convergence retraction nystagmus. And here you can see this Papilloma, which is wonderfully shown in the sagittal MRI, compressing the tectum of the midbrain, and it's beautifully illustrated even the post-contrast sagittal MRI. So more often we see elderly patients who are having some sort of Parkinson's-like features with defective eye movements who come to us. You can see this lady has, she's kind of demented, and she has difficulty in her horizontal eye movements. The horizontal eye movements are there, but they're very slow and very difficult to initiate. But what is more important is that there is absolutely no vertical movement. There is absolutely no upgaze or no downgaze, and that is what is classically known as the progressive supranuclear palsy, which is seen in elderly patient with Parkinson's-like features. So if you look at the MRI, the sagittal MRI will show a characteristic hummingbird sign due to preferential atrophy of the midbrain tegmentum without involving the pons, giving this characteristic hummingbird sign, and axial MRI will show you this Mickey Mouse sign. So in Parkinsonism also you may get gaze abnormalities. So this is a gentleman with Parkinson's disease, and if you look at him, you can see that his horizontal eye movements, both saccades and pursuits, are very slow, and the vertical eye movements, the up gaze is limited, but that's very common in a lot of elderly patients. But in his case, the down gaze is pretty good. So he's having Parkinson's disease, but his complaint was actually difficulty in reading the double vision for near, and see what happens. He's getting an intermittent exotropia when he tries to look for near. So that was the reason why he was getting diplopia, and he was better with prisms for near, though the disease, when it progresses, it will make the condition worse. Okay, so how do you confirm whether you're dealing with a supranuclear lesion or an infranuclear lesion? So if you're able to elicit the vestibular ocular reflex, as is seen in this video by the Dalza maneuver or the oculocephalic maneuver, you can be rest assured that the lesion is supranuclear, because I already told you the vestibular ocular reflex pathway is different. Okay, so let's move on to some quick case scenarios. So this was a young boy who had a severe RTA. He had severe subarachnoid hemorrhage. He was on ventilator for many months, and he came to us with a partially recovered third nerve palsy. And you can see he's got an exotropia. The horizontal eye movements are, there's a mild limitation of adduction, but there was absolutely no elevation or depression. And what was more interesting, if you look at the video, is that you can see that when he was trying to look up, he was going into a horizontal nystagmus with no up gaze or down gaze at all. Even with the vestibular ocular reflex or Dalza maneuver, we were not able to elicit a vestibular ocular reflex on Dalza maneuver. And both pupils were mid-dilated, non-reacting. And you can see here the left was more dilated than the right. There was total absence of convergence and accommodation. So this was due to a direct involvement of the midbrain, the nucleus of the third nerve, as well as the vertical gaze centers and the convergence and accommodation centers. So this is my last case. This young boy was brought with complaints by his parents of funny head movements and not looking at toys properly. So you can look at him carefully, see how he is trying to track an object. So when you shift his attention to a different toy, see what he does? He does a head thrust. So he's not able to initiate a saccade to rapidly shift his gaze. Instead, he uses a vestibular ocular reflex to initiate a saccade. So this condition is known as Oculomoto Apraxia, and he had a condition known as Joubert syndrome with this molar tooth sign on the MRI, the elongated superior cerebellar peduncles, giving the characteristic appearance of Joubert syndrome. So this is Oculomoto Apraxia, and this was one reason for the same. So to take home pearls from this talk would be that as ophthalmologists, we often forget to check saccades and pursuits and emergencies, but if you check them, you may get a lot of information. Saccades are controlled by the contralateral frontal eye field, and pursuits are controlled by the ipsilateral posterior parietal cortex. Remember that the horizontal gaze center is in the pons and the vertical gaze center is in midbrain. Supranuclear lesions involve both eyes simultaneously, and they don't usually produce diplopia, and the vestibular ocular reflex is preserved in supranuclear palsies. Thank you.
Thank you, Dr. Neena. It was absolutely brilliant. I would want to have the neurologist come in first before we move on further. Suresh and Sachin, please. And then we'll have Rashmin. Rashmin wanted to say something?
Yeah, I mean, she covered it beautifully well. One point I wanted to highlight is, and she differentiated as well, is why do you need to differentiate between Parkinsonism and progressive supranuclear palsy? Because their clinical features are quite similar, and a lot of PSP also would be started with levodopa. But what you have to understand is that once even the horizontal gaze goes in somebody who has been diagnosed as having PSP, the prognosis for life becomes a little worse. I mean, they generally within a year, the mortality rate is high, versus Parkinsonism, where they have typically decreased blink rate, reduced convergence, and sometimes the slow movements. The saccades are slow, but generally prognosis for life is worse in PSP versus Parkinsonism.
Okay, I think it's very well localized. The one problem with this supranuclear issues, pathway problems, are that the lesion could be anywhere in the pathway. So it's not, doesn't have a real localizing value to one point in the brain, because the pathways are quite long and it could be anywhere. Certain things like, the gaze preference, what Dr. Neena said, like in an epilepsy, the gaze is away from the irritating brain. And in a paralytic lesion like stroke, the gaze preference is towards, is very important in ICU settings, because sometimes there the patient wouldn't be speaking anything. And you look at these eye movements and then make the, whether should we ask for an EEG or should we ask for an MRI. So these decisions are taken there. And as Dr. Gandhi said, like even in differentiating between slow degenerative diseases like Huntington's disease, Parkinson's syndrome, supranuclear gaze palsy, as we typically see in PSP, it's very important to look at the vertical and saccadic gaze. PSP especially, the down gaze gets affected early, and then the whole vertical gaze gets affected, and then finally the horizontal gaze also get affected as this. So this typical vertical gaze is quite typical of PSP. INO, internuclear pathway, yes, INO is fairly localizing to the till medial longitudinal fasciculars, and mostly seen in minor strokes and also in MS, multiple sclerosis. INO is quite, whenever you see an INO, I think you should do an MRI to look for multiple sclerosis. Then you have the problems in the parapontine nucleus, like, you have the burst cells and the pause cells. So the overactivity of or underactivity of the burst cells will lead to slow eye movements, or slow saccadic movements, pursuit movements, while overactivity would lead to very fast movements like, ocular flutter and ocular dysmetry. This, along with the cerebellum, also has got a control over these type of movements. Whenever you see ocular flutter, ocular dysmetria, you always think of the cerebellar connections, the vestibular and the nucleus fastigious involvement in this. So fairly, some of the lesions have got a localizing value to a particular center in the brain, a particular part of the brain. Mostly you cannot localize to one point, and I think we need to look at the whole pathway, and the lesion could be anywhere in that pathway. Gopal, you're muted.
Dr. Gopal, you're muted.
Yeah, Sachin, you wanted to add something?
Yeah, so, I keep saying that the brain exists to serve the visual system. 60% of the brain has something to do with the vision. So if you have a large enough neurological lesion, you are going to find some ophthalmic biomarkers. Some of these are specific, some of these are non-specific. As Dr. Suresh said, INO is very localizing. So in a young patient, new onset INO is MS till proven otherwise. In an old patient with INO, it is stroke till proven otherwise. One other rarely detected sign is anti-saccade, which means you ask the patient to generate a saccade in the exact opposite direction to which you're presenting the stimulus. And that has a localizing value to the dorsolateral prefrontal cortex. So frontal dementias can do that. A word about Parkinsonian diseases. Typically, Parkinson's disease has very few signs of ocular dysmotility, the commonest being convergence insufficiency. PSP has the most, and somewhere in between is multiple systems atrophy, especially the cerebellar variant. So when I see, patients with neurodegenerative diseases, my movement disorder colleagues usually ask me to differentiate between 2 or 3 conditions, and these are the ones that I can help them with. Generally, I cannot help them if it is a simple Parkinson's disease because they are essentially normal. So when you see patients with Parkinson's disease in your practice, remember 2 things which bother them the most. One is convergence insufficiency, which prevents them from reading. The second is dry eye, which is seen in almost 80% of these patients. And we don't know if it is due to reduced blink or if it's a primary degenerative disease of tear production itself. So you can help them by just doing 2 things, give them prisms and give them artificial tears.
I'd like
Next
to
one, I
add
will
just a
invite.
point to that. Sometimes when the down gaze is affected to quite a large extent, we've seen that even prisms, in a slightly more advanced situation, even prisms produce diplopia in these patients because of the down gaze palsy. So in these patients who are desperate to read because they have no other activity to perform, the practical solution that we can give them is reading stands to make reading possible while they are looking they're in the orthophoric position, looking in the primary gaze, so that you give reading stands. And as Dr. Sachin said, give them lubricants for the dry eye. I think practical solution wise, so we have to devise reading stands depending upon each patient's level of effect, level to which his motor system is affected.
In the
Dr.
US,
Nina, you would like to introduce Dr. Pradeep Sharma? Now I think it's 8. We should move on.
Dr. Sachin, you were saying something, a quick remark?
Yeah, so there are music stands in the US, where they put the music.
Yes.
That.
Yes.
And in advanced cases, the only thing that helps is monocular occlusion. And that, because prisms are not tolerated by advanced.
Exactly.
So Dr. Pradeep Sharma, welcome. I'll quickly introduce you, sir. So Dr. Pradeep Sharma is going to talk about acute onset diplopia, how to work up and differentiate the various diagnostic dilemmas. So we all know, sir, he's a doyen in the field of strabismus, pediatric ophthalmology and neuroophthalmology. He's currently the professor and head of the department of RP Center, AIMS, New Delhi. He has more than 150 publications to his credit, and we're all familiar with his book, Strabismus Simplified. He has authored many chapters in renowned books, and he's one of the most eminent teachers and speakers we can ever have on this webinar to talk to us on acute onset diplopia. Very hearty welcome to you, sir.
Thank you, Dr. Nina. Am I audible? Yeah.
Yes, sir.
Yes,
Thank
sir.
you, Dr. Nina. And I would like to especially thank Dr. Sai Kumar and Dr. Gopal for making me a part of this excellent exercise for a subject which is usually not covered. So thank you for having this and the Cochin Ophthalmic Club. So we have already had a very nice talk by Dr. Nina on the motility problems, and she has simplified my job to a large extent. So when we have patients complaining of diplopia, what do we deal with? First of all, I think we'll have to make sure that it is binocular or monocular. So the monocular ones we need to be ruling out, maybe because of a refractive error, incorrect alignment of specs, corneal opacities, cataract or dislocated lens or IOLs, polychoria, maculopathies, RDs in CSR or CNS causes itself may be causing. I would like to specifically mention sometimes a simple thing which is usually missed. Now this girl had esotropia. She was operated, and after the surgery also she was still having complaints of diplopia. So when I looked at her, I found the problem was not in her eyes, because the moment I removed her glasses, there was no diplopia. It was only when she put on the glasses there was diplopia. The problem was decentered glasses, and the moment we corrected the glasses, her problem was sorted out. So I think we should be aware of these things which can be there. Coming to the binocular diplopia, that means when the diplopia is taken care of when you cover one eye, they can be intermittent or they may be constant. So intermittent may be because of myasthenia or intermittent decompensation of phorias. The constant ones are more likely to be because of the nerve palsies, maybe the abducens, oculomotor or trochlear nerve, or an internuclear ophthalmoplegia sometimes. The orbital diseases, the orbital apex syndromes has already been covered by Dr. Rohit, or the associated cavernous sinus thrombosis. These may result in multiple ophthalmic nerve involvements or post-trauma. So these may present to us in different forms. So we may have an irritative lesion, as Dr. Nina had mentioned, in cases of the gazes. Similarly, there can be an irritative lesion, but rarely so when we have for individual nerves, but mostly we come across with paralytic strabismus. And the classical thing is that the deviations are binocular. Secondly, they are different in different gazes. So there's an concomitant strabismus that you'll see, the double vision is there. The causes has been covered, but the point that I would like to specify here is whenever we come across a patient complaining of diplopia, always look into the fundus to rule out a papilledema. That is something which we need to always emphasize that should be done. Another thing is a confrontation fields. I think this has been covered very nicely by Dr. Sachin. So many times in the busy practice also, you should always do a confrontation field and then follow up with a specific 30-2 or 25-2 fields. A pass pointing may be seen by these people who complain of acute onset of diplopia, and you can actually see that a person is having this. And similarly, diplopia can be charted in which direction it is there, whether it is horizontal or vertical, and detailed estimation can be done in the orthoptic lab. So these you may come across. A recent onset 6 nerve palsy will show up differently in a Hess chart, as you can see here, compared to a older 6 nerve palsy, in which you will see the spreading comitance visible in the form of almost symmetrization of the incomitance, which is seen on the Hess charts. Another thing which we sometimes don't do and we should be doing is the binocular fields of fixation. The areas in which there is single vision and the areas which are having double vision. These are important for prognosticating or following up the people who have a diplopia. A force reduction test may be done whenever you have a doubt whether it is a restrictive or a paralytic strabismus. Long-standing paralytic strabismus may have a restrictive component added, and then you can differentiate it from by doing an active force generation test, in which you will see the tug which is generated by holding the globe with a forceps. Now, how do you evaluate a case? Now, first of all, we talk about the third nerve palsy, which is the nerve which is having the maximum confusion which can be presenting to us. In the history, there may be an onset. Is it asked from the patient, has it been there, how long? Fortunately, many patients with ptosis may not complain of diplopia, but the moment you lift their lid, they will be complaining of diplopia. Is there any associated severe pain? Now, this may give a very important indication of what could be the cause. It may be a sharp shooting pain associated with an aneurysm. The duration and the constancy of the diplopia will be further evaluated. History of trauma, any road traffic accident, any systemic illness, especially ischemic diseases, or any associated myasthenia or a thyroid should be also inquired. And similarly, any previous surgery should be seen. Now, so when you have a complete third nerve palsy, you will have the complete picture, but you should first of all see whether the pupils are involved or not. So when we So in the evaluation of a case of third nerve palsy, the important considerations would be to look for pupillary reactions. And we will have a nice talk by Dr. Rashmin Gandhi on details about the anisocoria. But remember, whenever there is an ischemic third nerve palsy, there would be either pupil sparing or very slight anisocoria, maybe just about 1 to 1.5 millimeter difference. This is true for about 70% of the cases, but sometimes there may be a more severe involvement, and 25-30% cases may have a pupillary involvement also. Movements in all gazes should be looked for. Any ptosis associated has to look for. Aberrant regeneration, if there is definitely a concern that this is not an ischemic lesion. Other associated cranial nerves, papilledema, fields, and general physical examination you look for. So,
sir, is there a problem with
So
the
you are
audio,
not audible, sir?
Is it, am I audible now?
Yes, yes.
Yeah, you are audible, but is there YouTube?
I think in some of the slides, there was an overplay of some sound that way.
Yeah, I think all of us can be muted. All of us can be mute. You know, somewhere it's getting replayed. Whatever sir is telling is getting replayed.
So in the pupil sparing cases, I think we need to investigate for any associated ischemia. The common ones are hypertension, diabetes, coronary artery diseases, hyperlipidemias, and homocystinemia, which should always be looked for. We had done a study and we had seen that in a series of 50 cases, we had almost the 60 to 70% cases having associated diabetes. This may also have associated hypertension in some of these cases. So these cases, you should always, the good thing is that they will recover on their own. So observe them. Whenever you have a case in which pupil sparing is there, keep on a follow-up, call them after 5 days. If there is any delayed pupillary involvement, then you can easily see that there is something else. Otherwise, it may be a purely an ischemic third nerve palsy. Recheck every 4 to 6 weeks. Usually the recovery begins in 6 weeks time, and many a times it is usually fully recovered by 3 months. But if there is no recovery, or the pupil is dilating, or there is any additional neurological problem or aberrant regeneration is there, or a progress of palsy is there, you need to immediately do an imaging in these cases. An MRI or MRA would be warranted. If pupil is involved, but the imaging is negative, such cases you may have to do a lumbar puncture to rule out any other pathology. So when to do imaging in cases of third nerve palsies? Whenever you have a pupil involving case, always. But those cases which have pupil sparing also, you may have to see if the age is less than 50 years, if there is any associated incomplete third nerve palsy, and then follow up, it shows pupillary involvement, or there are any additional neurological features, or there is age is less than 10 years, any aberrant regeneration is not likely to be in an ischemic problem, and if the improvement is not occurring. So the aberrant regenerations, so I think these things we may, in the third nerve palsies, it's important to remember that whenever the nuclear third nerve palsy is involved, there will be a bilateral ptosis and not a unilateral ptosis. So whenever there is a unilateral ptosis or a unilateral pupillary involvement, it has to be a fascicular lesion. So this is something which is almost to be remembered in a case. And if there is a bilateral ptosis, think of a nuclear palsy. Associated syndromes which may be there, we may be associated with the, as Dr. Sachin had also mentioned, you would have to look for associated features. If there is any hemiparesis, contralateral, or there is an ataxia and tremor, then these would indicate for a Weber's or a Benedict syndrome, or a North-Nichols when there is an involvement of ataxia because of cerebellar peduncles. Am I audible, or because I have muted my slide?
Yes, sir. You are very well audible.
Is it audible now?
Yes, in between it's going off, but you're audible now.
You're very well audible, sir.
So internuclear ophthalmoplegia has nicely been covered. Sometimes you may have associated medial rectus involvement with that, and I would not like to go into it. In third nerve palsies, wait a minute. I think there is some. Surgery for the third nerve palsy then would be maximal section of the horizontal whenever there is a.
So now it is not audible.
You're not audible now.
Am I?
Now you are. Yes, sir. You are.
Yeah, now you are, sir. I think there must be some loose contact sometimes. Maybe.
No, I think there is some slides which have a audio.
Voiceover there.
Oh,
I think there is a
okay.
voiceover in your slides.
Yeah,
sir.
I think there is some slides which are having a voiceover. So, but basically, when we have to manage these cases, remember, if there is a eye which is crossing the midline, then we can get away with an R&R. But otherwise, we may have to think of doing more drastic procedures, which we will talk about in some other more detailed things. But these are when we do the transposition of the LR to MR, or the medial periosteering of the lateral rectus. Whenever we have an aberrant regeneration, we have, like this case, we had a 20-year-old male with outward deviation of the left eye for the last 1 year. Drooping of the eyelid was there, and he had an aberrant regeneration. Now, these cases, when we see, we can easily assess this for an aberrant regeneration, and a contralateral third nerve palsy will usually be helpful. So this was a post-traumatic case after a third nerve palsy with pupillary involvement and aberrant regeneration. So after following up for a requisite period that no recovery is there, we can then manage to correct it by doing the contralateral eye surgery. Now coming to the sixth nerve palsies. Wait a minute. The sixth nerve palsies, as has already been mentioned, may be associated with the PPRF lesions, and that is something which you will be picking up in the history, or any associated problems which may be because of infections, or the vitamin deficiencies in the form of thiamine deficiency may be there. But otherwise, as I said, a nuclear sixth nerve palsy again can be differentiated just like for the third nerve. In a nuclear sixth nerve palsy, it is usually going to be an asymmetric conjugate gaze palsy. It differs from a gaze palsy that there is a adduction limitation, which is partial. It's an asymmetric lesion compared to a conjugate gaze palsy. There can be associated syndromes in the form of Millet-Gubler's, Raymond's, or the Foville's syndrome. Depending on the site of the lesion of the sixth nerve, there may be associated syndromes which will help us guide which is the location of this problem. Like Gradinigos may be having involvement of fifth, sixth, seventh, and eighth nerve, and the petrous bone fractures will be indicating that. A pseudo-Gradinigo syndrome may be associated with the nasopharyngeal carcinoma or a CP angle tumor. The lesions in the cavernous, sinus, the orbital lesions have been covered by Dr. Rohit in the ophthalmoplegia, which may be there. Now, for the paralytic strabismus, the general rule is that in the non-surgical management, in the period that you're waiting, you may give prisms, or you may occlude the eye for the avoidance of diplopia. Segmental occluding devices can also be given. In the intervening period, we may give injection Botox to expedite the recovery. So once we have seen that it's not an ischemic problem and the recovery is not occurring, and in the intervening period that you're waiting, you may give injection Botox. This is specifically more so for sixth nerve palsies. Otherwise, we wait for about 6 months and follow up every 6 weeks till no change is seen. So management of abducens palsies, if we have seen for 6 months, then we can see we may do a recess resect procedure if the eye is coming or crossing the midline. But otherwise, we may have to do a transposition procedure in the form of Hummelsheim's procedure. The Jensen's procedure is something which we usually do not recommend. Now, this is an individual who has a sixth nerve palsy, but the eyes are crossing the midline, and such individuals can be benefited by an R&R procedure. But otherwise, you may have to do the transposition. And for transposition, as I have said, there may be an options of Hummelsheim's. Nowadays, what we do is Hummelsheim's procedure with a Foster's augmentation, which may be done. And these are the posterior fixation sutures, 5-0 ethibond sutures we are applying 8 millimeters behind the insertion to increase the vectorization forces of the vertical rectus, which we are transposing. Now, this girl, she presented with a sixth nerve palsy. We had followed up, she had not been recovering, and she typically, such cases will present with a head posture. They will have diplopia in the primary position. That's why they keep a head posture to have the eyes in the position in which the eyes can be maintained into alignment. After the surgery of a transposition, a vertical rectus transposition, she has been corrected very well. Nowadays, we try to do a partial VRT, a vertical rectus transposition, which is of partial width, and we cross action we use and put it on an adjustable suture so that we can correct it more correctly and do not leave any diplopia post-operatively. Strabismus fixus cases, if associated with high myopia, if they present, then you need to do an orbital scanning to see if there is a shift of the position of the superior recti as they appear to be there in this picture. And this would be indicative of a nasalization causing a severe position of this, which is causing the lateral rectus not to be effective as it is in the inferior compartment. Such cases may benefit with the loop myopexy of lateral rectus and superior rectus. The superior oblique palsies typically present with a head tilt. Now, whenever you have a case presenting with a head tilt and you straighten the head, he complains of diplopia, which is usually vertical, you would like to do a testing and see if the contralateral head tilt test is worsening the diplopia and the upshoot. Now, this is typically seen in a superior oblique palsy. So the 3 steps can be done. And when you do the diplopia charting, you will be able to differentiate. Always look for torsion in such cases. And this is a very important thing, that whenever you have a torsion which is more than 5 degrees, and this is also seen on the Hess charting. So look for the torsion into the fundus. This is something which you cannot miss. Even if there is a child and complaining of a head turn, you look into the fundus, there is a shift of the fovea, which is out of the 2 horizontal lines, which are the lower border of the disc and the upper 2/3 and 1/3 junction. So how do we suspect a bilateral supraoblique palsy? The supraoblique palsies usually have a history of head trauma. Sometimes we can also have seen after a ischemic pathology, but mostly they have a head trauma. Subjective complaints of torsion may be seen. Objective torsion is more than 10 degrees in these cases. Alternating hypertropia on either sided head tilt we can do, and this will confirm as in this individual. And they will typically have a chin down head posture as against a right-sided or left-sided head posture. They have a V pattern, and this is the reason why they have a chin down posture, because they can maintain their alignment to correct the ESO in the down gaze. Management of the supraoblique palsies, we may have to do the inferior oblique recessions. We are not talking of the management right now, but we may have the options of these. Even the severe inferior oblique palsies, the supraoblique palsies, we may manage with the inferior oblique stagers procedure nowadays, and that takes care of most of the inferior oblique overactions. This is a bilateral supraoblique palsy. This is managed with the Heredito procedure. And you can see this individual who had been seen earlier, how he has been managed, and this will correct his bilateral supraoblique palsy. So I think this is in short about the overview of the paralytic squints which may present in the form of binocular diplopia.
Thank you very much, sir. Thank you very much for taking us down the memory line about 22 years. Thank you very much, sir. But I think you are troubled by the recording on the slides.
Yeah, I think some of these slides have come, and I didn't realize that they are having an overplay. Sound over. I'm sorry for that. Yeah. So if there are any questions, yes.
Yeah.
That was a very nice talk, sir. So very good sound knowledge of strabismus is very important in picking up the causes of acute diplopia. That's the gist I understand from your talk, sir. So I think there are no more questions on the YouTube right now. We'll come back to sir's talk later if there are any more questions. Can we move on to the next talk? We are a little running late. Are there any questions from the panelists?
Are there any questions or comments from the panelists?
If there are no questions, I'll ask Dr. Rashmin Gandhi to start his talk on anisocoria, analyzing pupillary defects. Dr. Rashmin is a very familiar figure in neuro-ophthalmology circuits. He's a double FRCS from Edinburgh as well as Glasgow. He is currently the MD Beyond Eye and Healthcare Private Limited, consultant and director of the neuro-ophthalmology department at Center Site Hyderabad, and also consultant at Datta Meghe Institute of Medical Services, Varda. He is a founding member and vice president of Indian Neuro-Ophthalmological Society and is a visiting professor at University of Hyderabad. He has numerous accolades and awards to his credit, and some of the important ones would be the Award for Academic Excellence for the Honorable Chief Minister of Gujarat in 2011, none other than our current Prime Minister Narendra Modi. He was a senior consultant in Shankar Nethralaya for a very long time, during which he was a recipient of many awards. And his current interests are in development of new technologies in ophthalmology, education, and community outreach program. He is a member of International Council of Ophthalmology's Technology for Education and Ethics Committee. Over to you, Dr. Rashmi, for your talk on anisocoria.
Thank you, Ina, for this nice introduction. Would like to thank Cochin Ophthalmic Club, Sai, Gopal, and everybody for inviting me for this very nicely crafted webinar. And it's always a pleasure to meet and discuss with all of you. So my talk today is on anisocoria. And before we move on, there are 2 points that I would like to make before we move on to the cases. Number one, remember anisocoria can be the first or the only sign of a serious neuroophthalmic disorder. And the examination, the clinical examination of anisocoria is to pick up which system or which eye, which pupil is at fault, whether smaller pupil is at fault or a larger pupil is at fault. And the way to do it by clinical examination is to observe anisocoria in light environment and in a dark environment, in a brightly lit room and a dark room. If the anisocoria increases in a dark room, what it tells you is that one of the smaller pupil did not dilate, implying that the sympathetic system is at fault. If anisocoria becomes worse in a bright environment, it tells you that the larger pupil did not constrict, implying again that the parasympathetic system is at fault. With that background, let's look at some of the cases. The theme of the webinar is emergencies in neuro-ophthalmology, a case-based approach. So let's have a look at some of the cases. This is a lady who was initially diagnosed as having cataract and RAPD by somewhere else. And you see here that she has ptosis of the right eye, and the ocular motility is being tested with the torchlight to highlight that the right pupil is larger than the left pupil. You see, when the patient looks to the left and the right, the horizontal gaze seems to be okay. See what happens when the patient tries to look up. So the horizontal gaze seems to be fine, and when the patient tries to look up, you'll find that the elevation is grossly limited in the right side. So this was a patient who had a ptosis, acute onset ptosis with elevation deficit, a mild depression deficit, and involvement of the pupil. That pupil was larger. So this patient clinically had partial third nerve palsy with anisocoria. Now, as Dr. Pradeep Sharma sir has already highlighted, anisocoria in the setting of third nerve palsy is an emergency. The reason being 8 to 10% of the cases where there is anisocoria and a third nerve palsy can be because of aneurysm, and close to 30% of these cases, 60% of the cases would have compressive lesion. So why it's an emergency? Because aneurysm, there are 2 places in the course of third nerve where there can be aneurysm which compresses in the third nerve. The important one is posterior communicating artery aneurysm, which can rupture, can lead to subarachnoid hemorrhage, 50% mortality before patient attains medical help, and remaining 50% of the patients, more than 50% of the patients would have permanent neurological deficit. And that's the reason why, and can bleed anytime. So pupil involvement in a third nerve palsy, so anisocoria in the setting of third nerve palsy is an emergency. Now, this rule of pupil does not apply to partial third nerve palsy. If the patient has a partial third nerve palsy, whether the patient has anisocoria or no anisocoria, that patient warrants investigation. The investigation of choice would be MRI with MRA or CTA. You want to rule out aneurysm in these patients. The second point, which was highlighted by Dr. Pradeep Sharma, is that not every compressive lesion produce anisocoria on presentation. If the compression is because of aneurysm of posterior communicating artery, they are more likely to have anisocoria on presentation. However, 14% of these patients may not have pupillar involvement on presentation. So all these patients, as Dr. Pradeep Sharma mentioned, would warrant regular follow-up, initial follow-up maybe every 5 to 6 days to make sure that pupil is not getting involved little later in the course of the disease. If the compression is in cavernous sinus, if the aneurysm is near the cavernous sinus, then the pupillar involvement would be later in the disease. So anisocoria present on presentation, immediate, it's an emergency, MRI with MRA or CTA. If anisocoria is not present, even those patients would require follow-up to make sure that anisocoria is not developing during the course of the disease. So that's about larger pupil at fault, third nerve palsy. Let's look at another example of the same this lady also had a larger pupil on the right side, had limited adduction and elevation. Surprisingly, the ptosis had not developed that yet. This patient also had aneurysm of the posterior communicating artery. Case number 2, this 30-year-old lady had an accident. She was involved in road traffic accident, had a fairly severe injury with injury in the neck. She, after around 5 days after the injury, she presented with complaints of headache. And if you can see on this projection, you'll find that the left pupil is little smaller than the right pupil. And this difference, anisocoria, was worse in the dark, implying that patient had Horner syndrome of the left side with pain. And this patient had a history of injury, which probably involved some injury in the neck. This is an emergency because Horner syndrome, painful Horner syndrome, can be because of dissection of larger vessels, especially if patient gives history of trauma. So a painful Horner syndrome, acute onset after trauma is an emergency because this patient might be harboring dissection of larger vessels, which can throw up an embolus. Patient can develop MI or stroke anytime in the future. So case number 2, emergency, painful Horner syndrome. The other causes of painful Horner syndromes can be Horner syndrome with headache, which can be in the setting of trigeminal neuralgia, or a shoulder pain, which can be because of Pankos tumor. The other features to look at to confirm the presence of Horner syndrome would be presence of mild upper eyelid ptosis, or also lower eyelid ptosis, which will give an appearance of relative enophthalmos, and the affected pupil will constrict faster than the other pupil because there is no sympathetic supply. So that was case number 2. This is case number 3, anisocoria, localizing. So here you see, and I would acknowledge Dr. David Z from Baltimore gave me this video, and you find that patient is looking at the OKN drum, and you find that the patient has a convergence retraction nystagmus, and this patient also had anisocoria. This was a patient with dorsal midbrain syndrome. Dorsal midbrain syndrome, if the lesion, if there is a lateral lesion which disconnects pretectal nucleus from Edinger vascular nucleus, those patients of dorsal midbrain syndrome will present to you with anisocoria. There'll be other features, and which Dr. Nina beautifully mentioned. There can be upgaze palsy, there can be light near dissociation, there can be convergence retraction nystagmus. We move on to case number 4. Here you find this lady which I saw last month. She complained of difficulty in near vision, not corrected by glasses, and you find that left pupil is little bigger than the right pupil, and you'll find that the anisocoria, the difference in size of the pupil was worse in the bright light. So here you're looking at a parasympathetic system problem, no other associated feature. Patient only had mild difficulty in reading with both the eyes. So you're probably looking at Ades pupil. How to confirm? One of the tests is ask patient to read for a little longer period of time, and you'll find that the affected pupil will constrict slowly. So patient has to typically read for 30-40 seconds for you to see a constriction, and then ask patient to look at a far object, and you'll find that there will be equally slow dilatation. And that's the reason why it's called Ades tonic pupil. So a slow constriction to convergence and a slow redilatation to divergence is one of the signs of Ades pupil. And the confirmatory test would be instill diluted pilocarpine in both the eyes, and you'll find that now the pupil, affected pupil, has become normal size. So Ades pupil, generally harmless, generally unilateral, can be bilateral in 20% of the cases, and generally after few years, the pupil becomes smaller, does not cause any other problem. These patients may have a difficulty in near vision, and that can be corrected by giving suitable glasses. I generally don't give pilocarpine, though it was prescribed in olden days, and pilocarpine works well to alleviate the symptoms of lack of accommodation. Ades syndrome is where there is delayed tendon reflexes. Come to a last case. This is not really anisocoria, though the previous report of this patient suggested that patient had a larger pupil on the right side, and he presented with difficulty in bright light, and difficulty in doing his near work and the computer work. Though when he came to us, he had large pupil on both the sides. And all the tests were performed. He had undergone MRI, MRA several times elsewhere, and all came back normal. And it was not fitting into anything. There was no effect on this pupillary size with reading, with diluted drops, diluted pilocarpine drops. Then a little detailed history revealed that he was actually posted in a job which he did not like. And this was more like a non-organic cause of initial anisocoria. And then he started applying those dilating drops at home in both the eyes. And so to conclude, anisocoria can be the serious manifestation of an underlying disorder, both parasympathetic and sympathetic. Acute onset anisocoria with neurological signs and symptoms warrants immediate investigation. Thank you once again.
Thank you, Dr. Rashmin. That was a very nice presentation with beautifully illustrated videos, and all the trainees, I'm sure they have been enriched by your experience and the videos. Are there any questions from the panelists?
So I think I want to clarify one thing about the cranial neuropathy and how do you and when do you image it. And I think a lot of it depends on resources also. So a few years ago, one of my colleagues in the US, Madhura Tamankar, she produced a paper which was multi-center and found that you have to image most of these cranial mononeuropathies, otherwise you miss about 10 to 20% of lesions. So I don't know how the rest of the panelists manage this, but what we do in the US is, well, at least what I personally do in the US is every acute third nerve palsy will be imaged. No questions asked. Whether the pupil is preserved or not preserved, it doesn't matter. There's no point in taking a risk with aneurysm like Rashmin pointed out. If the patient presents a few weeks after the third nerve palsy, then I might hedge, because by that time, if it was an aneurysm, it would have already been it would have burst. Sixth nerve palsies, I tend to lean towards imaging them unless there are clear-cut ischemic factors. And even then, I follow them up closely every 4 weeks. And if they are not improving, I will image them. Fourth nerve palsy, I don't image them if I'm sure if they're fourth nerves. Problem is sometimes you'll confuse them with skew deviation, or vertical skew deviation. And if it's a vertical skew deviation, you have to image them because that's an emergency. So Rashmin might know David Newman-Toker from Johns Hopkins, who came up with the HINTS test, where you have the head impulse negative, but if you have nystagmus and you have vertical skew, then it almost always points towards a posterior fossa lesion. So I think those are a few things that I've learned over the years with respect to these cranial mononeuropathies.
Sachin, that was a great point. And in fact, our lunch, we missed our lunch in Synapse meeting in Chennai because this question was raised at 12:45 and the discussion went on till 1:15. And in fact, your mentors were there. And the question which was asked was the same, that, well, we know that almost all cranial neuropathies now get imaged. So is that the norm, or do we still rely on the age-old clinical criteria? And the conclusion, as you very rightly said, depends upon a lot of things: availability, financial backing of the patient as well. We had published a paper on the sixth nerve in Indian scenario, looking at the large series retrospectively. And we found that anybody below 45, whatever patient may be having, sure imaging immediate. Above 50 with clear-cut vasculopathic risk factors, there were the number of patients who turned out to be space occupying lesion was minuscule. And so we said that, okay, if it's a mononeuropathy, no neurological signs, including no headache, and then follow them up every third, fourth day, and if no change, you can wait. Third nerve is a tricky situation. I know, in fact, I know that if you have an isocoria and if MRI CTA comes back normal, threshold for even an invasive angiography is low because you don't want to take a chance there. And it's a tricky situation, yeah. I would like to hear from panel as well.
I just wanted to ask Dr. Sachin, because my understanding that a skew deviation, how to differentiate a skew deviation from a fourth nerve palsy. My understanding is that a skew deviation will not obey the Park's three-step test. Is that so?
So skew deviation may obey the three-step test also, but I think the most reliable, well, actually it's not really reliable. In about 50 to 60% of patients, if you test them in an upright position and in the supine position,
yes,
the vertical deviation changes. It almost completely resolves,
yes, because of vestibular influence.
Yeah. So as soon as you eliminate gravity, the vertical skew will get better.
And
again,
also I think
about 50 to 60% of patients only. So you have to, again, if the patient is presenting acutely with a vertical diplopia, then I will image them irrespective of what they have. But if they present after a few weeks, by then the acute problems will have gone away. If I'm absolutely sure that the diplopia is because of a fourth nerve, such as the patient fell down, bonked his head, had a TBI, then I know that it's more likely to be a fourth nerve as opposed to a skew. If it's an old patient with vascular risk factors, then I think that this is a stroke. Then I do the Hintz test. If there is nystagmus, then your question is answered. If there is no nystagmus, and if head impulse is negative, I will wait.
And also, I think the double Maddox road also will give you a clue whether there's extorsion or intorsion. It's more in favor of a superior oblique, isn't it?
Yes, but it's difficult to assess that in an acute setting. So, I'm talking about if the patient is in the emergency room and you're called in as a consultant. It's very difficult in those cases to examine.
I think so. The bottom line is that the threshold for imaging in cranial nerve palsy is slowly going down. And what we heard from Dr. Nancy and Dr. Valerie was that almost everybody now gets imaging. In fact, if you remember, there was a paper by Andrew Lee where a 6-nerve palsy where imaging was not done, and then it turned out to be apoplexy, and actually patient didn't do well after that.
Yeah.
So,
Yeah.
I think shall we move on to the next talk?
No, Suresh, do you have to say something?
I just would like to add to what Dr. Gandhi had said, that sometimes in ADs, people may be seen in other conditions like Guillain-Barré syndrome, dysautonomia, and trauma. So it just means that there is a lesion in the ciliary ganglion. So basically, sometimes they may not be completely benign, and it may be a part of an underlying other disease. Like, you need to see what accompaniments are there with the ADs pupil. So I think we need to look into that. But most of the time, it's harmless, and ADs people are benign. But sometimes they do point towards a ciliary ganglion lesion. Actually,
Deep Sharma sir or Naveen sir?
I would essentially agree with Rashmin that the threshold for scanning, especially the problem is in the third nerve. And with the third nerves, I think nowadays we tend definitely to lean towards imaging them straight away. And as Dr. Sachin said, whether the pupil is involved or spared, it really doesn't matter. I think the only situation where I would watch a third nerve is if the ophthalmophilia were complete and the pupil were completely spared clinically. And the patient is over, say, 50, 55 years old with ischemic risk factors, I would probably wait and see. But in all other situations, definitely I would consider scanning these patients.
Yeah, I think we
Next
can move
talk,
on, Nina.
Dr. Gopal, shall we move on?
Yeah, I think we should move on. Yeah.
Yeah, so without much delay, we will invite Dr. M.V. Francis to talk on acute onset headache, differentials of headache presenting to an ophthalmologist. Dr. M.V. Francis is currently the Chief Consultant at Teresa Eye Care and Migraine Center, Cherthala, Alapi, Kerala. He did his undergraduation and post-graduation from St. John's Hospital, Bangalore, and fellowship training in headache from Trinity, Cambridge by European Headache Federation and British Headache Society. He has authored 4 textbook chapters and a book called Neuroimaging in Headache Disorders, a case-based approach. He has even proposed certain criteria to define migraine, especially in pediatric migraine, and he has altered some criteria. He is a founder, member, and treasurer of the Headache Society of India and is a scientific committee and chair of Asia Pacific Headache Society. He is also a reviewer of Annals of Indian Academy of Neurology. Over to you, sir.
Okay, thank you, Dr. Meena. Thank you, Dr. Gopal, Sai, and Dr. Arun. Acute headaches can present to an ophthalmologist with or without ocular or neuroocular signs and symptoms. They can come on any day, and there is a route map for them. Either they go to an emergency first, or to a GP or physician, then go to an ENT to rule out sinus infection, then to ophthalmologist, and then to a neurologist.
Sir, please initiate slide sharing. Sir, your slides are not being shared here.
Not coming?
Slide transition is not happening, sir.
Yeah, he has to move on to the next slide.
I think I had to go to slideshow if I'm not mistaken.
Sir, please initiate slideshow or play the slides. So please go to slideshow.
Yeah, now you can share again and full screen, sir. Yeah.
Fine.
Now I can full screen.
Okay?
Yes, sir.
Okay, thank you. Sorry for the initial hit. So there is a route map for these patients. They either go to an emergency, get injections and tablets, or they go to a physician or GP, then to an ENT physician to get sinus infection tested, and then to an ophthalmologist, and finally to a neurologist. They come to an ophthalmologist either on their own or referred by other specialties, mainly to rule out refractive errors, glaucoma, and papilledema. And there are some very finer points in the history which will help you in decision making when they come. The most important of these finer points is the first 1 minute of the headache. You have to dissect the headache. How was the beginning? Was it explosive? Maximum intensity in the first 1 minute. If that is the case, that is known as thunderclap headaches. And the most emergent rule out is subarachnoid hemorrhage and aneurysm rupture. Why it is important? Because up to 50% can die within a week or two. And the most important and revered investigation is a plain CT. If you can get it done on day one, nearly 98% sensitivity. And even in the US, nearly 50% of these cases are mismanaged or misdiagnosed, and the commonest misdiagnosis is migraine. And those cases, all of them came during the first 1 week with thunderclap headache. They can also get diplopia, transient blurring, photophobia, and 20% of them will have subhyaloid hemorrhage. So when you look into the fundus, see that their neck is supple. There is no neck rigidity, neck stiffness. And not all thunderclaps are subarachnoid hemorrhage or aneurysm rupture. This lady, in fact, came on 4th day just to rule out eye pressure. And she had abrupt onset headache, not exactly thunderclap. So abrupt onset is the key. And if you go for CT on day 4 or day 5, there is a possibility you will not get anything. So you have to go for CT angio or MR angio. Ideally LP, but then many centers are doing now CT or MR angio. And this lady had multiple aneurysms. Now, when you decide on imaging, not all thunderclaps are going for CT, plain CT. This lady, postpartum day 2, came with thunderclap, admitted, and the day after admission, she was searching for her baby lying on the left. So everybody thought she has postpartum psychosis. It was left homonymous hemianopia. So once you localize the lesion retrochiasmatically into the visual pathway, you have to decide on MRI And in this case, because it is postpartum and the possibility of hypercoagulable state or prothrombotic state, you have to keep venous thrombosis as a differential and go for MRI with MRV venography. You can see the right venous thrombotic infarct. And this youngster came with gross blurring of vision on the left side with thunderclap headache. And when you go into the history, he had mild blurring, on and off blurring for the last 2 months. 2 spectacles were given, but he was not happy. So that is the main thing which you have to keep in mind when you prescribe glasses for blurring of vision, vague blurring, temporal blurring, on and off blurring. See that they are happy with the glass. Otherwise, let them come back. You have to reassess and do a visual field. Minimum confrontation and Amsler. This was apoplexy. You can see the blood there in the superior part of the pituitary adenoma. Now, acute onset headache is not always very severe intensity headache. It can be mild moderate headache, tension type headache, which nobody is bothered. Though this lady had acute onset mild moderate headache, tension type headache, she was not bothered. Then she had blurring of vision for reading. So one spectacle given, there was no improvement, and then she came for second opinion. And she had endocrine symptoms like galactoria, which she thought is physiological. That is why when they come with recent onset headache and visual blurring, always look into the endocrine symptoms, galactoria, amenorrhea, sexual dysfunction, temperature dysregulation, which may be diagnostically very helpful. And pituitary tumors can present with any type of headache, migraine, tension, or cluster. And this lady, again, 70-year-old, presented with acute onset headache and blurring of vision. And always remember BP to be checked. This is an entity known as PRES, posterior reversible encephalopathy syndrome, or reversible posterior leukoencephalopathy syndrome, where you have, edema in the posterior part of the visual cortex in the occipital lobe. When you have blurring of vision bilateral and there is nothing in the eye, you always focus on to the visual cortex posteriorly and go for MRI. And at the same time, check BP. Not only in acute onset headache, any headache you have to check BP. BP is very important in headache practice. And you have one thunderclap, you get 50% mortality. What about multiple thunderclaps? It is very funny. Multiple thunderclaps are actually benign, known as RCVS, reversible cerebral vasoconstriction syndrome. And you get it from very trivial triggers: sexual activity, showering, bathing, bending, emotion, exercise, Valsalva. So these triggers must be specifically asked when they come with multiple thunderclaps. In fact, this man was doing tough yoga posture. He had thunderclap, went to an emergency, took injection, subsided. Next day he had thunderclap again. So he decided to come to an ophthalmologist to rule out any spectacle problem or eye pressure. And again, you have to go for MRI, CT, usually normal. You can get, depending on the vessel spasm, you can get edema, infarct, hemorrhage, but usually negative. So you go for MRI. MRI angio, CT angio will show you the spasm. You can see the vessel spasm there. Here and there you can see vessel spasm. And sometimes first week you may not get anything positive. You may have to wait for another 1 week to get a positive MRI. And the commonest of the headache syndromes, acute headaches that coming to any OP, any emergency, is actually migraine. Migraine without aura. So how do you diagnose migraine without aura? This is exactly opposite to the thunderclap headache. These headaches are slowly peaking, very slow onset, and it takes some time, 20-30 minutes for the maximum intensity pain to occur. And they have usually a trigger, and usually it is throbbing, and there should be a past history of similar headache some years back or months back, and usually a family history of migraine or headache. And rarely you can get ophthalmoplegic migraine, now known as RPO, recurrent painful ophthalmoplegic neuropathy, which is a pupillary involved ophthalmoplegia. Third nerve and sixth nerve also can be affected. And they also can present with autonomic symptoms. All type of autonomic symptoms are possible. Periorbital edema, lacrimation, congestion, twitching, meiosis, ptosis. So when they come, be very careful. If it is the first 1 or 2 episodes, especially above 40, one must keep in mind subacute angle closure glaucoma. And the differential in this case is another benign headache entity known as trigeminal autonomic cephalalgia. And where you have agitation. This is my mnemonic. You can remember this mnemonic. Obama in. O means one-sided or orbital. B means brief episodes. AM means autonomic manifestation. And the big A is agitation. Migraine patients will be keeping quiet, taking rest, going into a dark room, trying to sleep off. These patients will be restless and agitated. IN means endometritis. Surprisingly, 2 of these entities dramatically respond to endometritis. And when you have migraine aura, 1/3 of the migraines get visual aura, that is the aura most of the patients get, where again they come with blurring and headache. In fact, this lady presented with one eye blurring and acute headache. So, RBN was diagnosed because there was nothing in the eye. So when the doctor blind, patient blind, you go into the diagnosis of RBN, retrobulbar neuritis. And within 3 days, other eye also became blurred and she had something like cortical blindness. But once you go into the history, it was typical visual aura, gradually progressive visual hallucination, flickering scintillation. So nobody, tried to dissect that initial visual blurring. Later it becomes scotoma and they will come and tell you, I am blind in that eye. So always dissect. And if you get a slowly progressive, savadana, dhira, progressive visual hallucination, progressing over a period of 5 minutes and lasting less than 60 minutes, it is nothing but migraine aura. If it is lasting more than 60 minutes, like in this lady, it becomes persistent aura. So immediately you have to rule out migrainous infarct. One must go for stop protocol of MRI. This was delayed in this case. And if the visual hallucination is brief and colored, and if there are automatism, blank stare, rapid blinking, gaze deviation, then you consider that as an epileptic attack. And in transient ischemic attack, especially above 50 with risk factors, it will be negative, curtain shadow falling, and usually it subsides within 15-20 minutes. And acute progressive, again, this youngster had mild to moderate headache, which was diagnosed as tension type headache. So everybody thought all symptoms that he was complaining after that was, typical of tension headache, like transient blurring, transient diplopia, tinnitus. So nobody gave any importance for that. And papilledema was missed. Papilledema symptoms also were missed. So this is a sagittal sinus thrombosis. You can see the anterior part totally occluded. So always see that any acute onset headache, whether it is mild, moderate, severe, doesn't matter. Acuteness is more important. One must be very careful and consider that as a red flag and do complete assessment of this patient. And if possible, refer them to a neurologist for opinion. And sometimes you have to open the curtain. Patients will come with severe acute pain and there will not be anything on external assessment, and you open the curtain to see the focal neuritis. And you can also diagnose primary trochlear headache, the trochlear inflammation where you have to palpate at the trochlear region and you get pain there, and also frontal headache. And they also get eye movement induced head pain. In fact, any inflammation, including a minimal Hordeolum, can also precipitate acute headache if the patient has a migraine trait or a headache trait. And sometimes, it is a different headache. They have migraineurs, they get migraine headache maybe months or years back, but they come with an entirely different headache. They tell you, this is not the usual headache that I get. This lady presented with supraorbital headache with partial ptosis, which was, superior division third palsy, ptosis, mild ptosis, and mild supraduction deficit. So CT was taken normal, MRI taken normal, no dedicated orbital view was taken. So always localize the lesion and go for dedicated cut with coronal and contrast. Contrast cuts will show you the lesion. You can see that enhancing lesion there, that is the LPS supervex complex of idiopathic orbital inflammation. And acute capillary, There are cabaret presentations in acute headache presentation, like a cabaret dancer slowly exposing herself. These entities first present with headache, orbital pain, and the localizing diagnostic signs and symptoms manifest over a period of time. There are 8 such entities. So you have to wait for a few days to get the localizing sign. And the commonest is herpes zoster ophthalmicus. You know that eruption vesicle. This for this lady was on 5th day. They come with burning pain, itchy pain, stabbing pain. And second one is Tolosa-Hunt syndrome. 13th day, up to 14 days, they can present with pain. And I was the 5th doctor. She consulted 4 people before that. And this is the mitosis and diplopia at that time when she came. Then you have temporal arthritis or giant cell arthritis, where they get mild to moderate throbbing headache, and visual loss will be after a week or 2, and you can see the dilated superficial temporal artery, and also you get carotid dissection, where they present with acute onset headache, facial pain and neck pain, and diagnostic Horner syndrome will manifest only later, maybe after 3 or 4 days. And same thing with Vogt-Koyanagi-Harada syndrome, and also brainstem demyelination, optic neuritis. They can also present with vague temporal headache or frontal headache, and it can go up to 28 days before blurring of vision occurs. So these are, cabaret presentation where you have to be very careful to prescribe any new tablet or a new brand, because whenever they get these different lesions later, they may attribute that to the drug that you had given. So always see that you give them something which they had taken in the past, explain to them what exactly you are anticipating, and investigate as and when they get a symptom. So in conclusion, whenever an acute headache presents to you, go for a meticulous history, including triggers, and dissect blurring, dissect headache. And a basic ocular neuro-ocular assessment will save the day for you. Thank you.
Thank you very much, sir. Thank you very much. Any comments from Revati Madam, our neurologist, or any other people in the panel? Yeah.
There is a question on YouTube. So is this hemianopia in, I think it's related to the headache, the reversible occipital encephalopathy syndrome. Is it reversible, and how long can we wait?
Which one, Dr. Nina? Which hemianopia?
Couldn't hear you.
No, I think the question was that if there is a stroke or something like that which causes a field loss, should we do thrombolysis? What is the indication for thrombolysis? 1, and number 2, if you thrombolize early, will the visual field recovery be faster? And number 3, what is a natural course of events? How many people will have recovery of fields? How many people will not have? What is your opinion? Yeah.
To me,
I think we'll need
neurologist
the
can take the question.
Yes, the neurologist in our panel, please.
Yeah. So that was a beautiful talk by Dr. Francis. All the, the red flags of headaches were mentioned over there. So to go back to the question that was asked, I think that I'm a little confused. If the question was for reversible cerebral vasoconstriction syndrome, you don't thrombolize those patients. Now, if a patient has symptoms that persist for more than an hour, like Dr. Francis said, then you're more likely dealing with either persistent migraine aura, or you're dealing with an acute ischemic stroke, or you're dealing with posterior reversible encephalopathy syndrome affecting the occipital lobe. In those cases, we would actually look at the patient as a whole, get the initial stroke workup, which means CT angiogram or MRI angiogram. And then if we are certain that this is acute ischemic infarct, then they will follow the same protocol that we use for any other acute ischemic stroke, which means get a NIH stroke scale, And if it is 6 or more, and if they are within the window for thrombolysis, then you will treat them with IV thrombolysis. But if it is a reversible cerebral vasoconstriction syndrome, you will not thrombolize them. As far as improvement is concerned, if it is a transient ischemic attack, by definition, they will get better within 24 hours, or you use 24 hours as a cutoff to differentiate between TIA and a full stroke. I hope that answers the question.
Yeah, I do agree with with Dr. Sachin that you wouldn't thrombolize a patient with.
So just be a little loud.
Yeah, definitely we wouldn't go for a thrombolysis there, because if you see, there are various presentations of this syndrome actually. Now, if you take an imaging, you can see infarcts, you can see blood in the brain, you can see actually hemorrhage, you could see a subarachnoid hemorrhage in RCVS. And if you take the angiogram and if you look at the CT angiography, you will see the vessels are all narrowed off, and they are like completely vasoconstricted. That's why it's called a reversible vasoconstriction syndrome. It takes some time and then it to reverse back to normal. So it's called a reversible vascular. But many times bleeding is a part of this, imaging of this disease. And you really don't want to do anything, thrombolize. The last thing you want to do is thrombolize this patient and make a larger bleed. So definitely, yeah, I do agree with Dr. Sachin on this, the point on this. And for me, always the problem is, when should I image a patient with headache? This has been always a perennial issue in the outpatient clinic, because if your threshold for imaging is low, then people do not like it actually. And if you're because migraine is one of the most common cause of headache, and it can present like all these presentations can be there in migraine. They can be very severe acute onset, and disabling and with autonomic symptoms. Everything can be there in a migraine. So you really want to make the difference whether are you facing a severe form of migraine or are you really looking at something, more than that. So for me, actually, some of the points which would help me to go for an imaging is, I would agree with Francis, the thunderclap headaches, very severe headaches, acute onset, even in a patient with migraine, not improving, you need to image. Headaches which are very localized and constant to one part of the brain or one part of the brain needs imaging at some point of time. If the headaches are so severe that they disturb your sleep and you're not able to sleep, and the headache scales are quite high, 9 out of 10 on a VAS, then probably yes. Any lateralizing sign seen with headache, it's better to image such headaches. These are some of the points which I would go by, and of course papilledema. If any patient with papilledema, I would definitely like to image. So the challenge is always when to image and when to ask for a scan in such patients, even in patients with migraine. So you need to just keep some of these points in mind when you're asking for an image. Anything to be added by Dr. Sachin on this, like on a routine headache, when you want to do a imaging?
Yeah, so I call these red flags of headache. You and Dr. Francis have alluded to most of them. So new onset headache above the age of 50 years is another one that I use. Change in the characteristic of headache that Dr. Francis has alluded to. Accompanying systemic features like fever, chills, weight loss, or symptoms suggestive of giant cell arteritis is another red flag for me. Accompanying neurological signs or symptoms, including papilledema or motor or sensory deficits, is another one. Signs of infection like zoster, as alluded by Dr. Francis. Lateralizing headache is one that I think every ophthalmologist should be aware of, which means you beat the patient and torture them and ask them, are you 100% sure that the headache is always on the right side? If they say, no, 90% it's on the right and 10% it's on the left, then I think it is migraine. But if they say, nope, it's always on the right, it's always behind the eye, it's always on one side, you will have to image, because that means that there is a lesion there.
There are, mnemonics, Snoop, Snoop 4. I have my own mnemonic, which I think we need a very long time to discuss here.
I just wanted to ask you, what about in pediatric patients? Are there any differences in the nature of the headaches or any?
Yeah, they are very brief. Their headaches are very brief, and basically, you start from the first day of life. Infantile colic, that is the first migraine manifestation, which can come on day one of life, and then they go into episodic syndromes. They get abdominal pain as abdominal migraine. They get, on and off vertigo, paroxysmal vertigo. Then they can get cyclical vomiting. They, whenever there is a trigger, they vomit. So migraine actually in pediatric age group is not in the head. It is in the neck, abdomen, and they can also get periodic limb pain. It can be limb pain, yeah. Then on and off they get headache. And those headaches will be very, very brief duration headaches. Maybe 20 minutes, 30 minutes, yeah. So where you have something very commonly that I have documented is motion sickness. They have the travel sickness. That is a very early migraine manifestation. So you have to correlate. When they come with, short duration headaches without typical migraine features, you go into all these associated and past history. So you can easily diagnose migraine.
May I add two more points to that? One is the familial hemiplegic type of migraine, also seen in children and young adults. So familial hemiplegic type of migraine, and sometimes migraine equivalents. They just present with aura and not much of migraine symptoms, headache, but they would present with the aura of it. So that's also seen in children. So migraine equivalents. So these are some of the The rest of the point I think already has been told by Dr. Francis.
Shall we move on to the next talk? Yes. Yeah. We come to the last talk of the webinar. Nevertheless, a very important topic. It's on transient vision loss, diagnosing and managing transient obscurations of vision by Dr. Naveen Jaikumar. Dr. Naveen Jaikumar is also a very well-known figure in neuro-ophthalmology circuits. He's currently the Honorary Director of Darshan Eye Clinic, Chennai. He was the head of the Department of Neuro-ophthalmology at Shankar Nethralaya, Chennai till 2005, when he was invited by the Chinese University of Hong Kong to establish a neuro-ophthalmology department there. There he was awarded, he was recognized for his work, and he was awarded Hong Kong's Action for Vision Foundation in 2006 for his exemplary work. He was a member editorial board of one of the world's premier scientific publications, the Journal of Neuroophthalmology USA. He is the first and the only Indian and one among the 3 Asians to be invited to this position. He was conferred the Achievers Award by the Asia Pacific Academy of Ophthalmology in 2016. We heartily welcome you, Dr. Naveen Jaikumar.
Thank you very much, all of you, for having me here today. And I know it's the last talk. It's 9:15 in Chennai. I don't know what time it is for Sachin there, but I think he's better off. Okay, so I thought I'd start with this kind of interesting looking map, which I think you must have been looking at as to what is this all about. I'll come to this right at the end. So my talk today is transient visual loss. And I had a couple of clinical questions, which I think it's important for us to determine the answers to these before proceeding further. So is the monocular transient visual loss, is it monocular or binocular? What is the time profile or the temporal profile of the symptom? Are there any precipitants to the visual loss? And are there any visible retinal or optic nerve abnormalities? As far as monocular or binocular is concerned, for monocular disease, we need to know the location. It could be anywhere from the eye, from the retina, all the way to the orbital structures at the back. As far as circulation is concerned, it could be anywhere from the heart all the way up to the central retinal artery. And of course, migraine is also an important consideration for anyone with a monocular visual loss. As far as binocular visual loss is concerned, the same things apply as I spoke on the previous slide, except it's on both sides. But in addition, we need to think about papilledema, we need to think of vertebrobasilar insufficiencies, and migraine, our usual suspect, is also here as well. As far as time periods are concerned, classically, we look at transient visual loss is occurring, just lasting very, very briefly for a few seconds, or is it lasting for minutes, or is it several minutes to hours? So the transient, just a few seconds, could be optic nerve ischemia or papilledema. Those lasting about 2 to 30 minutes or so, think of embolism, carotid artery disease, and several minutes to hours, migraine is the one, the usual suspect for that. Sometimes amaurosis or transient visual loss can be associated with certain peculiarities, such as gaze evoked, especially when the patient looks the lateral gaze in intraorbital masses because of a mass compressing the optic nerve circulation. There's a kinking of the optic nerve that happens. In addition, you can have light-induced transient visual loss that happens because of the retinal biochemistry getting compromised due to severe vascular insufficiencies. So when the light is a little excessive, the retina is not able to function very well. And that's light-induced transient visual loss. Similarly, because of a mesenteric steal syndrome, you can have a postprandial visual loss also has been described. Then, of course, is the examination of the fundus. Is there anything wrong with the disc, or is there papilledema, or is there any congenital disc anomalies, or can we see any visible retinal emboli in the fundus? I'd like to talk a little bit mostly about monocular transient visual loss, which is what we commonly encounter. And as far as gaze evoked is concerned, as I mentioned, is it orbital lesions like cavernous hemangiomas and meningiomas especially frequently can cause this kind. We associate gaze evoked with these particular conditions. There are certain other conditions as well which are listed here. Very, very rarely, idiopathic intracranial hypertension can also cause this because of the swollen optic nerve, and the eye moves, it kinks and cuts off circulation as well. Sometimes monocular visual loss can be reading evoked, but apart from orbital apex masses in which this can happen, please also consider intermittent angle closure attacks, which the patient may be describing as a transient blur which is happening. The examination of the eye, usually it would be normal, or you might find symptoms of optic neuropathies or orbital disease. Please also check the angle of the anterior chamber for narrow angles, because that could be a symptom as well. And the investigation would obviously include an MRI looking at any orbital issues. For the monocular visual loss lasting seconds, by that we arbitrarily put it as less than 60 seconds. It's due to a compressive effect on the central retinal artery where it enters the optic disc. And here the suspicions are papilledema, usually describes this. And I always ask my patients whether they're having papilledema patients, when they're having a transient visual loss, it's a kind of a red flag or a warning sign that things are not going very well with the optic nerve and function is getting impaired in some form. The other two conditions I had mentioned earlier, which is meningioma and congenital disc anomalies. The imaging, the investigations for this obviously includes imaging for idiopathic intracranial hypertension or space-occupying lesions, and orbital MRI as the case may be. But if you have a normal fundus and a normal imaging, we need to check for sources of emboli even in these patients. For the monocular visual loss, which lasts minutes, by that I mean maybe 5 to 60 minutes, but usually it's about 2 to 30 minutes or so. Thromboembolic disease is the one that comes to mind first. Patients may complain of a shower of bright specks that clears up quickly. The source of the emboli can anywhere be from the heart all the way to the aorta and the carotid arteries in the neck. These are areas which need to be looked at. The hallmark, of course, when it's established, where there's not much you can do, is of course the cherry red spot that you see there. This is an interesting patient where the ciliary retinal artery has been spared, and so this circulation is maintained. The patient will have some vision, but the peripheral retina is affected. As you can see here, there's a lot of retinal edema. You can get emboli. These are the cholesterol, the Hollenhorst plaques that you can see. The calcium emboli are a little larger. They get stuck at the disc level, which you can see here. And very rarely you can get this kind of a fibrin platelet emboli along the blood vessel here. I made this slide some time ago, but I thought it's still worth looking at this particular slide with the message that it conveys to us is patients with retinal emboli have a significantly higher risk of dying with stroke than those without retinal emboli. So it's important for us to keep this in mind, and the association of visual retinal emboli with visible other diseases, as you can see here, with pressure, hypertension, diabetes, smoking, etc. So please do keep this in mind. It is important for us to remember this. There are other causes for monocular transient visual loss associated with blood circulation, such as hypoperfusion, carotid dissection, where our earlier speaker had mentioned, I think Rashmi had mentioned, with painful Horner syndrome, venous stasis retinopathy, giant cell arteritis, always a suspect, and vasospasm/migraine as well. I think we should consider giant cell arteritis, especially in the very older individuals. It's an important condition, and the treatment is completely different from what we normally would consider for thromboembolic disease. And its effect on the eye and the system is equally bad. So I think it's important for us to remember giant cell arteritis and not forget about it. There are other odd situations where patients may complain of monocular visual loss. Apart from the angle closure attacks that I spoke to you about, you can have hyphema, pigmentary glaucoma. You can see this condition occurring sometimes following a scleral buckle, and occasionally congenital disc anomalies can also present with this. The investigations, of course, look at the heart valves, aorta, and the carotid arteries by Doppler and echocardiogram, and also please evaluate for stroke risk factors as well. One of the hallmark studies of the 90s was, of course, the North American symptomatic carotid endarterectomy trial. Essentially, what it said was this, that if the carotid artery, internal carotid artery is blocked, is greater than about 70% or so, then okay, go ahead with the carotid endarterectomy. If it's between 50 to 69%, it's only moderately effective. So essentially, you have to take other clinical factors into account, as well as what is the mortality rate of doing the procedure, which I think they marked it as about 6% or so. So it could vary from hospital to hospital, as I understand it. So, but definitely less than 50% of stenosis, please don't do an endarterectomy. Medical treatment is far better. So that was the study. There have been other studies, such as the CREST study, which has come out later. But this was the mother of all carotid endarterectomy studies, I would say. Monocular visual loss, which lasts for hours, it's very rare, I think, in thromboembolic disease. I think one should remember the postprandial with migraine and impending central retinal vein occlusion, as far as ophthalmologists are concerned. I think that is an important symptom to keep in mind. Binocular transient visual loss. Well, I think here I wanted to stress upon migraine, which is basically medical treatment, versus occipital lesions, which are a far more serious situation. One of the differences is, of course, in occipital lesions, there is no typical march and resolution of the visual symptoms, the blur, and it comes back in 20 minutes and stuff like that. The symptoms actually steadily increase in frequency and duration until the patient may even sometimes be having it every day. The aura is usually, if an aura is constantly being localized to one area of a visual field, that is a little suspicious. And the aura episodes may be independent from the headache. You may, normally in a migraine, you would first get the aura and then the headache in a classical migraine. And in this case, you may first get the headache and then the aura as well. Other things, as I said, apart from the localization, again, the visual symptoms of the headache may also be localized, consistently right or left-sided. Papilledema, hemianopias are something that we need to look for in occipital lesions, which may or may not be present in the migraine patients. My last area is the vertebrobasilar insufficiency. And there are other symptoms, therefore, of transient brainstem, cerebellar, or posterior cerebral ischemia. One would expect to find, always ask a history for cerebellar symptoms and signs associated with a bilateral transient visual loss. The bilateral symmetric visual impairment is usually hemianopic or diffuse, 1 to several minutes, definitely not in seconds. Scintillating scotomas and expanding scotomas, these are very rare in VBIs. So in summary, transient visual loss is associated with potentially vision-threatening and sometimes life-threatening conditions as well. So we have to think about it as an etiology, as what are you dealing with? I think clinically looking at it seconds to minutes to hours is a good way to start off. Keep in mind the embolic and hemodynamic circulations, ocular problems, stuff inside the eye, neurological disease, and finally, of course, idiopathic as well, which comes to this particular map. This was when I was in Shankar Nethralaya. This is a map of Madras, a certain area of Madras. And there was this patient who was here. He was having some business here. And he was driving his car along this road when he suddenly felt the vision in the left eye just dropped as he was coming down here. And the first thing he did was, since he was here, he just went all the way up here, down. It was barely a few minutes away, and he reached us at Shankar Nethralaya here. So that was probably luck. So when he presented, he was in the left eye, he had barely perception of light. The right eye was absolutely fine. He had no other symptoms, no headaches, nothing else. And this was at 5:30 in the evening. And on some days, I do not know, many of you in Nethralaya, we have usually some Swamiji comes and gives a talk or something, and it usually happens at 5 o'clock in the evening after OPD hours. So all the consultants were there. And me being a neuro-ophthalmologist and my colleague, Dr. Nitin Shetty, was a retina specialist, we were also standing near the emergency when this person walked in, and we were called by the postgraduate student. So we looked at this man, virtually no PL in the left eye. Look at the pupils. There is a gross RAPD which is going on. There's a clear RAPD there on the left side. Fundus, absolutely normal, nothing happening. So my question to all of you is, this is a patient who's come like this. We thought he's having a central retinal artery occlusion, but we can't see anything going on in the fundus, but that doesn't really mean anything. So we did the usual paracentesis thing and the massage, ocular massage got. So in about half an hour, I think we were done with whatever we needed to do for him at that point in time. At about 2 hours later, he said his vision was about counting fingers, able to see a little bit. So we patched his eye and told him to go home. And he came and met me the next morning when his vision was about 6/60. He could read the top line on the board. And by evening, a couple of days later, I think his vision had come back to almost 20/20. So my question to all of you, I've always thought about this gentleman. I think what we did was correct at that point in time, but it's a little difficult to make out when just there's a no vision, an RAPD, and very catastrophic visual loss, suddenly over minutes. Was he having just an amaurosis, or was he actually having a central retinal artery occlusion? So were we right in doing a paracentesis, etc.? I'd like the panelists' opinion about this because I'm still thinking about that patient. Sachin, do you have any comments on this, Sachin?
Yeah, that's an interesting presentation. With the presence of a RAPD and no light perception, whatever happened to him was real. It was not migrainous. Whatever happened to him was retrobulbar. It could have been ophthalmic artery occlusion, transient, which then subsequently broke off down the road. It could have been posterior ischemic optic neuropathy, which is unlikely or rare. I hate to call it migraine because it doesn't do no light perception.
Yeah.
I would say that this was a ischemia that was retrobulbar in nature, whether it was the ophthalmic artery or it was the ciliary artery occlusion causing ischemic optic neuropathy, who knows? But I'm glad that he got some vision back.
Yeah, but I always think, should we have done a paracentesis and thing, or would you have just said wait and watch? Because
I think
I waited and watched, and he was still no PL the next day. That would have been really terrible.
No, I think you did exactly what you had to do. The only thing that we would have done these days with that kind of a suspicion for retinal artery occlusion is would have considered thrombolysis as well. Although there is no definite proof it works, but we would have tried.
Okay.
Dr. Naveen and Dr.
Retinal artery
Sachin,
occlusion.
what I understand from your talk, you beautifully said that emboli to the retina are more dangerous than they have a higher risk of producing stroke.
Yes.
You said that. So I think Dr. Nancy Newman came out with this article which said that every patient with central retinal artery occlusion should be should be imaged. Because very often we don't, because they could be, harbinger of future strokes. Because these emboli may be, diverted to the retinal circulation in favor of the cerebral circulation, and they have a higher, risk of stroke. So I think the protocol now, I understand, Dr. Sachin, you can help me if I'm wrong, is that every patient with acute CRAO, you should consider it like a stroke. And you should do a diffusion-weighted MRI to look for any, lesions or any lesions which are predictive of stroke and managed like an acute stroke. Refer to a stroke specialist as well. At the same time, taking care of the CRAO at the earliest and ruling out other, causes of the thromboembolism.
The patient did undergo all the required protocols and tests after that. If I recall, we did the carotid Doppler and the thing and the blood, everything, but it has always been niggling around at the back of my head as to how much to react when you see this, because if there's the problem being that if it's in minutes, this patient just came literally in minutes because of where he was located. And normally a patient would come after several hours, by which time would probably start to see retinal edema and CRAO. What do you do?
I had a fortune of seeing one patient in the ICU, in the orthopedic ICU, and he had a sudden loss of vision. And I came in within minutes of his symptom starting. And I saw that, there was perfectly normal retina. If I compared between the two eyes, there was slight pallor in one eye, not so much pallor. But so it takes about 2 to 3 hours or even up to 6 hours for a cherry red spot or any other, significant change to develop. So I think with a significant RAPD, with almost normal retina and with sudden loss of vision, central retinal artery occlusion, which you reversed with your paracentesis, may have been the diagnosis.
So the point I wanted to make was in severe retinal conditions such as this, probably you will get an RAPD. It's not like that you won't get an RAPD. You will get an RAPD. Probably not as much as the degree of RAPD you might get with an NPL with optic neuritis, which would be a really severe RAPD, but you will get quite a significant RAPD in these patients. So, Rashmin, I think you must have still been a student then. I don't know.
No, I remember this case. We had a.
Remember this case?
yeah, we had a long discussion. I think we did the right thing because I don't think this was just a transient event which would have gone anyway without your intervention because it lasted for several hours. I mean, even next day he was not normal. He was still 660. He was
not completely normal.
Whatever edema which the stimulus would have triggered. So.
Yes.
So I think a couple of points that I want to make about this is, number one, the ophthalmic artery is the first branch of the internal carotid artery. So personally, I treat any retinal artery occlusion, whether it is celioretinal or central retinal or branch retinal, as an acute ischemic stroke. So to me, it is a stroke. Every patient will get admitted to our stroke unit and will undergo a complete workup, which means you'll get an MRI of the head, you'll get a blood vessel workup, you'll get a cardiac echo, and you will then treat them for their risk factors. The risk of a subsequent cerebrovascular or a cardiovascular event is greater than 10% at 3 months. So it is something that I take very seriously. The second point about transient vision loss that I think all the ophthalmologists who are watching this webinar is to differentiate between whether it is positive or negative, which means does the patient have positive phenomenon like photopsias? Is it very bright as opposed to did everything go dark and dim? So if it's dark and dim, it's ominous. Then it is ischemia till proven otherwise.
I think I'll add to that, like basically most of them are thromboembolic phenomena, whether it's cholesterol thrombi or whether it's a platelet thrombi, So basically the origin is from the great vessels or from the heart. So there are certain things which we should do. One is whenever you ask for an MR angiography, you should always ask with a contrast, and also start from the root of the aorta. Most of the thrombus are actually atherosclerotic plaques are sitting at the root of the aorta. So in a normal MR angiography, you wouldn't see that because they start taking somewhere from the neck. So you really need to ask to see from the origin, that is from the carotid itself, and even the vertebral artery should be actually seen from its origin. That's one thing. Always ask the cardiologist to do a trans echography, because you can miss small PF4s, etc. So you should ask for the special echography. And the third thing is probably we shouldn't miss out on seizures. So sometimes seizures can also present with visual loss, like especially from the occipital areas, like in hyperglycemic seizures. You can have both, as what like Dr. Sachin said. There could be a photopsia, there could be sort of a positive imaging. There could also be a negative visual loss also, which disappears as soon as you treat the seizure phenomena. So you get both in seizures. So occipital seizures in hyperglycemic metabolic conditions should also not be missed out in this.
Suresh and Sachin, I want to ask you the difference between a central retinal artery occlusion, which you're labeling as a stroke, versus a brain stroke. Basically, because the ischemic time in the brain is about 4 minutes. The ischemic time in the retina is 90 minutes, according to our, according to whatever we have learned. So, would you relax the criteria for thrombolysis, and will it benefit a patient? Like criteria for thrombolysis for a cerebral stroke is too rigid, and most of our central retinal artery occlusion patients would come to us maybe one day down the line. So, would you want to relax that thrombolysis criteria a little bit? If you are treating a central retinal artery occlusion, will it give benefit?
So the thrombolysis in central retinal artery occlusion is very controversial. There have been a few studies from Emory and other centers that have looked at this. There is no evidence that it works simply because of what you told us is patients don't come within that time window. Secondly, because it is difficult to get the right concentration to the site at the same time. So some centers have actually tried cannulating the ophthalmic artery and delivering thrombolysis through intra-arterial mechanisms. So the answer to your question is, if the patient comes in early enough, I will treat them like a stroke. There is no question. If they come within the first couple of hours, they will get the IV thrombolysis. Even if they are late, they will get the IV thrombolysis because you have nothing to lose. Otherwise, it's an irreversible problem for them.
Okay, so yes, 2 hours is the criteria, maybe up till less than 4 hours. Suresh, what is your thought process?
Yeah, routinely we look at 3 hours. Maybe we CAS study has extended it up to 4.5 hours. So somebody who's doing a CT and thrombolizing the patient, I think should not do beyond 4.5 hours right now with the present guidelines, and should not attempt. But there are centers which actually treat strokes and have intervention centers of stroke. So they usually tackle strokes beyond 4.5 hours, So that's where all the intra-arterial thrombolysis and the combination of intravenous and intra-arterial thrombolysis and all takes place. So what Dr. Sachin said was a very special situation. We cannot make it into a routine, thrombolizing indication, because when we look at thrombolysis, you're looking at the most simplest hospital which can do thrombolysis to a very high-end hospital. So, everybody, the guideline should include all of them. You cannot have, when you make a guideline, you cannot be for thrombolysis, it cannot be for 2 different settings. So that's why it's a special situation where you're losing your vision, and it could be due to a stroke, and probably in a specialized center where you are able to handle, you could go and thrombolize. Why not? Should do.
I have a question for Dr. Sachin and Dr. Suresh as well. How important is relevant you think is the concept of diffusion-perfusion mismatch when you manage strokes between the diffusion image and the perfusion image on MRI? If the diffusion and the perfusion match each other, generally they say no need for thrombolysis. But if the diffusion is just this much, but the perfusion lesion is showing a lot more, then you say thrombolysis is important, which is what I have read and thought about. But I thought I'd ask the neurologists themselves what they think about this and how important is it in the management of stroke and deciding about thrombolysis.
So that's what Dr. Suresh was alluding to, is the expansion of that window in which you can do the thrombolysis and acute stroke management. So the initial guidelines are for 3 hours when you have nothing else. You're a basic center, you do 3 hours IV thrombolysis. Recent studies have shown you can expand it up to 4.5 hours in certain situations. But in the last couple of years, there have been a number of studies which have looked at mechanical thrombolysis, which means the neurosurgeon goes into the blood vessel and then draws the clot out. And that has expanded the window almost up to 24 hours now. So it's called the wake-up stroke, or patient goes well, wakes up in the morning with a stroke. Now, advanced stroke centers, or what we call as a certified stroke center, have the ability to look at what we call as a completely damaged segment of the brain, and also look at the surrounding brain, which is ischemic and salvageable. So that's the mismatch we are talking about. And the higher the mismatch, the greater the chances that you will recover brain function.
Yes.
So that is the reason you expand the window 24 hours, but you can only do it if there is brain that can be salvaged. Now, the difference between the retina and the brain is, if you have a stroke and it is an infarct rather than an ischemic brain, it is likely to bleed. And then you convert an ischemic stroke into a hemorrhagic stroke. And that can be fatal. So that is what we are trying to avoid when we are doing the mismatch ratio.
Yeah, I do agree with Dr. Sachin there. Actually, you're just looking by Dr. Naveen said, we are just looking at whatever brain can be salvageable and what is already gone, dead. That is infarcted. So if you have salvageable brain around the infarcted brain, then if you could still go ahead. But if there is no mismatch at all, and if you both are same, then probably you are not going to do much by doing. So again, this is the MRI. This we look at by MRI, and MRI is not really required for thrombolysis. Most centers don't have this facility to do an MRI. They thrombolize based on CT scans, where you would.
Yes.
So again, when you come to dedicated stroke centers, you could use all these additional sequences and mechanical thrombolysis, even intra-arterial thrombolysis. So all this, so we can push it up to 24 hours, as Dr. Sachin was rightly telling. But it depends upon your center and the capabilities and how much you deal with these type of problems. That's very important. For a basic center, CT, 3 hours, and just do it. give the IV intravenous thrombolysis.
Revati, madam.
Before we wind up, just a small thought to bring Dr. Gopal Pillai's views into things. We are hearing more and more about AP-MPP patients going in for stroke, and the need for these patients to be followed up by a neurologist. And we have a few comments on that from the neurologists and the vitreoretinal people. For years, we have looked at AP-MPP as a very benign condition, given them steroids sometimes and then left them alone. Any thoughts on this, Dr. Sachin?
Yeah, so a lot of these white dot syndromes, including AMP, falls under the category of what we call as uveo-meningitic syndromes, and they have neurovascular manifestations. Another disease is SUSAC. So these patients are managed differently by immunosuppression. I think, personally, this is my opinion, is every patient with an oculovascular disease like central retinal artery occlusion or branch retinal artery occlusion deserves at least one consultation with a neurologist, especially if they have other findings, hearing deficits, systemic complaints, which point towards an alternative diagnosis. Also, if you're suspecting that the patient has a retinal artery occlusion, then you have to do stroke prevention, secondary stroke prevention for them. So my personal opinion is if your retinal artery is blocked, no matter whether it is central, ophthalmic, or branch, it is coming from proximal sources, the heart, the great vessels, you have to image. You have to get a consultation.
Yeah, my thought process in it is that finally eye and retina per se is basically an extension of the brain. It is just that, they have divided and we have done division between ophthalmologists and neurologists. But the diseases don't know that. So I think in many of these diseases in which immunological involvement of the eye is there, probably immunological involvement of the brain will also be. So
yeah, the eye is merely an extension of the brain, right, Gopal?
Yeah, I know.
I think it's one of the most overlapping two specialities on a particular area, neuro-ophthalmology. I think we should bring the subspecialty up much more than what is there right now in India.
Yeah. Dr. Sai, I think we can.
Yeah. I think we had a wonderful meeting.
Yeah. And, so I think we should say that we have now about 2,700 reviews of this particular in YouTube. So 2,700 people have clicked and watched the program. And amazing faculty is what I say would be the reason for that. It's the who is who of neuro-ophthalmology, right from Pradeep Sharma sir. Thank you very much, sir. You have taken us 20 years back. At least me, Rohit, Sachin, etc. 20 years back. Thank you very much, sir. Naveen Jayakumar sir. I know that he had a quiz, an all India quiz which finished somewhere around 7 o'clock. Thank you very much for accepting us and joining us, sir. Thank you very much, sir. Rashmi,
not at all.
Thank you. You are a person who actually, he sends me messages, do this, do that, tweak this, tweak that. And obviously Rohit, who has helped me, design this program. And, thank you, Suresh and Sachin. We gained a lot by your presence. Francis sir, thank you very much. That was an amazing presentation. Thank you. Revati madam and Meena and Rehna. Meena has been the person who conceived this whole idea. And I think we should give her a big hand. Really, absolutely perfect, Meena. And Revati madam, thank you. Actually, what happened was I was not able to stream it on time and Prashok had to take over. And in 1 or 2 minutes, he made it all right. And in this confusion, actually, I forgot to give the link to our Kerala Society president. So Meena madam could not join us. I'm absolutely sorry about that.
Apologies. So apologies to Meena madam.
Yeah, I think we should thank Ashok Kumar Subramanian, who is in the microvision. Sir, do you wish to say a few words?
Ashok?
Yeah, once again. Yeah, I would like to say thank you. It was a wonderful seminar because I've been having eminent speakers and well attended also. So thank you very much. That's all.
I'd like to just thank Dr. Gopal. I know you probably, I can see Rashmi's hand behind the invitation to me, saying, go and call this guy. Just sitting around at home.
No, it is not Rashmi. It was our own thought process. No.
Anywhere and
Sachin, thank you.
Anything, I see Rashmi's hidden hand somewhere behind this. And it's so
No,
nice.
Rashmin told me.
See Dr. Revati
Rashmin
as
told
well.
me that you have a quiz on that day, and you also told me you push a little more. You will agree.
I can't say no to neuroophthalmology and I can't say no to quizzing, so I just do both. And it's great to see
And
Dr.
Sachin, it
Revati. I
is
think
so
we
nice to
last
see you
met.
after so many times.
Yeah, 15 years, Gopal. We were together, right?
And it was really,
Francis,
really nice to interact with Dr. Sachin and Dr. Suresh as well. It's wonderful to have, I think, eloquently speaking neurologists as well on this, interacting with neuro-ophthalmologists. There's so much of overlap, as you said, Dr. Suresh.
Suresh, thank you very much. It was really good. Thank you.
They say
we will bring this up much more.
They say the eye doesn't see what the brain doesn't know. So, so both are important, the eye and the brain.
I think we should not keep everybody from
Thank you so much.
Yeah.
Thank you very much.
Thank you, Gopal, and everybody.
Thank you so much, and bye-bye.
Bye-bye.
Thank you.
Thank you. Thank you very much. Yeah.
Thank you.
Okay, so I shall end the stream now.
Cochin Ophthalmic Club.